The wife feels the and that's it.
No, siamo tolti su poteva permettere per me c'è non c'è tempo. Non ho fatto neanche una stessa.
So ina ni kin fita da fatli na yanzu. Da sai da ga ina ni ki kawo yanzu.
Yana wurin ba?
Waya wurin ba.
A ce ba ni. Sai ya fata ba ne a ce ba na gani. Ja to karna kenan church ne.
Ko ne addu'a ne.
Kai zo je cancel church ba?
Cancel ne ba. Wai an ana cancel ne.
Hello, good morning, everybody.
Once again, we're looking at a theater.
Good morning. Am I audible?
You are.
Okay, thank you. Yes, so good morning once again. Welcome to this morning session of our the second CME. I want to welcome all of us here within Taraba and outside who have joined in this presentation for this morning. We are sorry for, well, not really starting behind schedule because what is on our program is 10 a.m. And our first presenter is already seated. He is going to take us through the challenges of common open bile duct exploration. Okay, for choledocholithiasis. Okay, the challenge in our environment. And Dr. Adams Marwa is our lead presenter this morning. The surgeon in Federal Medical Center, Jalingo, and he will take us through the presentation. Listen attentively, keep your comment or post your comment and question on the chat box, but we'll also give opportunity for people to ask questions directly. So once again, good morning. Thank you for joining us, and let's get started. Dr. Adams Marwa, please, the floor is for you to start your presentation.
Good morning, esteemed colleagues. I'm Dr. Marwa Daniel. I will be taking us through open common bile duct exploration for choledocholithiasis, challenges in our environment. I will do that under the following outline. Before we go further, let's take a look at the definition of some of the terms that will come across during this presentation. CBD means common bile duct. ERCP means endoscopic retrograde cholangiopancreatography. ES means endoscopic sphincterotomy. MRCP means magnetic resonance cholangiopancreatography. Cholelithiasis means gallbladder stones. Choledocus means the common bile duct. And the choledocholithiasis means common bile duct stones. Then the choledocholithiasis means the common bile duct stones. Okay, the means of introduction, cholelithiasis means gallbladder stones, and choledocholithiasis means stones in the common bile duct. In fact, stones impacted in the common bile duct. Cholecystectomy was first described in 1882 by Lagenberg, and in 1985, the first endoscopic cholecystectomy was carried out by the Moor of Oblingen. In 1889, the first common bile duct exploration was carried out by a Swiss scientist, Ludwig Courvoisier. Since then, up till now, he did that by the following: cauterization of the duodenum and short longitudinal choledochotomy, stone removal with palpation, irrigation with flexible catheters, and the use of the Jardine forceps. For many years, this has been the standard of treatment of choledocholithiasis. However, it will interest us to know that that has been for many decades. But up to now, in our environment, that is what we practice. In the 1970s, endoscopic sphincterotomy has gained widespread acceptance as a good, less invasive, effective alternative to common bile duct exploration. The prevalence of gallbladder lithiasis is roughly 20.5 million in the United States, with the sex ratio of men 6.3 million and females 14.2 million. That shows the female preponderance in this pathology. In Europe, however, it is reported to vary between 5.9 and to 21.9% in the general population. Please, this is what to take note, that 11 to 21% of patients with cholelithiasis have concomitant common bile duct stones at the time of surgery. This is the cornerstone of what we're going to see later. Vast majority of common bile duct stones are formed from the gallbladder, which then migrate to the common bile duct. Owing to the small diameter of the common bile duct distally at the ampulla of Vater, these stones tend to remain within the colodochus with varying degrees of clinical manifestations. The preoperative management of these patients is necessary in achieving good surgical outcome, and the common bile duct diagnosis and management have radically evolved or changed over the last 30 years. Endoscopic cholangiopancreatography, retrograde cholangiopancreatography has changed the approach to common bile duct stones. In earlier days, however, this evaluation of common bile duct stones or biliary lithiasis in general is based on clinical symptoms, pre-operative ultrasonography, liver function tests, intravenous cholangiopancreatography, which replaces the then oral cholecystography currently. We do endoscopic retrograde cholangiopancreatography, magnetic resonance cholangiopancreatography, and endoscopic ultrasound to aid in diagnosis of common bile duct stones. During the 1990s, evolution of laparoscopy has changed biliary lithiasis management even more radically by introducing laparoscopic cholecystectomy, which is the gold standard surgical treatment of gallbladder stones. Intraoperative cholangiography and laparoscopic common bile duct exploration is currently done. However, in the 20th century, critical appraisals of management options are considered, such as a more conservative attitude may be adopted to asymptomatic common bile duct stones, which are mostly diagnosed on, let's say, incidental finding following ultrasonography. But since more than 1/3 of these stones finally pass through without any complications, that's the more reason why the conservative attitude is adopted. It is interesting to note that in 2006, the European Society of Endoscopic Surgery guidelines update justify an expectant attitude in managing common bile duct stones in the elderly. Expectant attitude means that you adopt a conservative management protocol, which can change later if there is no progression of resolution of symptoms to the surgical intervention. Clinical features. Characteristically, the symptoms of the symptom complex of cholelithiasis consists of right upper quadrant colicky pain radiating to the right shoulder. Radiation to the right shoulder depicts the dermatomal innervation of most of the foregut structures. Then intermittent or fluctuating jaundice. This is very important clinical sign, symptom in a patient with stones in the common bile duct. And the intermittency of this jaundice will lead us to the various differential diagnosis of a surgical jaundice patient. Okay. Then the passage of bulky, foul-smelling pale stools or clay-colored stools. Most of these patients present like that. Body itching, okay? Then in some majority or small percentage of patients, they may present with easy bruisability. That's you see petechial hemorrhages, which may go on to ecchymosis, as the case may be. Then occasionally they may present with hematuria or bleeding from orifices generally, just to depict something like the GIC. It's good to know that some of these patients would present as a form of syndrome. The Charcot triad, for instance, seen in cholelithiasis patient with ascending cholangitis. This patient would present with a triad of fever, right upper quadrant, pain, and jaundice. If this Charcot triad in the patient goes on without any intervention, this may progress to septic shock, which is known as the Raynaud pentad. This patient will present with all the clinical symptoms of Charcot triad, with hypotension and mental status changes. Then the SEND triad. SEND triad, that's in the patient with common bile duct stones. They may have evidence of cholelithiasis, then hiatus hernia, and diverticulosis. The investigations to talk about, these are all part of the pre-operative evaluation of this patient with common bile duct stones. The liver function test, here you will come across raised serum conjugated hyperbilirubinemia with raised serum bilirubin. Then increase in alkaline phosphatase, gamma glutamyl transpeptidase are also evaluated, which are more important as compared to elevation of transaminases, such as the alanine amino transaminases and the aspartate amino transferases. Urinalysis, in urinalysis, you may see raised urine bilinogen, and the urine bilinogen may also be absent or negative. However, in situations where you have partial obstruction in the biliary tree, you may see traces of urobilinogen. So the fact that you see traces of urobilinogen doesn't stop the fact that the diagnosis may be what? An obstruction in the biliary tree. It's what to note that stool microscopy in the tropics is very important. In fact, there's an article that shows the pathology of common bile duct stones obstruction came from Ascaris lumbricoides as the causative organism. So stool microscopy, very important as an investigative tool in the preoperative management of these jaundice patients. Viral hepatitis B and C assay, also very important as such, because any jaundice patient that you see, two questions comes into your mind. Are you dealing with a surgical jaundice patient, or you are dealing with a medical cause of the jaundice? So this leads us to the essence of evaluating for the hepatitis B and other hemoglobinopathies. Let's look at the imaging modalities that will help us. These are the chest X-ray. Chest X-ray, more especially if you do the anteroposterior view and ECG. This is done in patients that are 40, 45 years and above to ascertain their fitness for surgery. Abdominal X-ray, abdominal ultrasound, magnetic resonance, cholangiopancreatography, abdominal CT. We'll see them later. More invasive investigations like the endoscopic retrograde cholangiopancreatography, endoscopic ultrasound, the percutaneous transhepatic cholangiography, and then the intraoperative cholangiogram or cholangiography. Why is it in literature, we know that about 10% of the population have their stones impregnated with calcium. That's what makes them radio opaque. That's the essence of doing the plain abdominal X-ray, for which you will see that acoustic shadow, evidence of the stone shown on the radiograph. You may also see the Mercedes-Benz sign, which is there, the porcelain gallbladder, which is extended, more leathery looking common bile duct. Then pneumobilia, which is highlighted here, or you may say an emphysematous gallbladder. Ultrasound in this management. In fact, ultrasound is a diagnostic tool or the gold standard of diagnosis of stones in the gallbladder. Remember, we said, even though we're dealing with the common bile duct stones, but about 11 to 21% of patients with the gallbladder stones have a concomitant common bile duct stones or obstructing the common bile duct stones. So ultrasound, very important. Is in ultrasound of the biliary tree, gives an accurate, it is quick, it's inexpensive, easily available, but the drawback is that it's operator dependent. Okay, it's an suboptimal scan. Ultrasound of the biliary tree may further give you the size of the gallbladder, the thickness of the gallbladder wall, and even evidence of inflammation, which is shown as peripolycystic fluid collection, and sonographic morphism can be demonstrated. The size of the common bile duct, normal size, ranges between 6 to 8 millimeters in diameter, and 6 to 8 millimeters in diameter, which can be measured using the ultrasound. Intraoperative and extraoperative biliary dilatations and the level of obstruction can be shown using ultrasonography. And ultrasonography is what to note. That is about 70 to 95% sensitive and about 80 to 90% specific in diagnosis of gallstones. The magnetic resonance cholangiopancreatography, this has really changed the diagnosis of common bile duct stones. It is non-invasive, doesn't require the contrast, and this demonstrates ductal obstruction, visualizes the stone, areas of strictures within the biliary tree, and other intra and extra ductal anomalies within the tree. This is the schematic representation of the pictures shown on cholangiopancreatography. That's magnetic resonance. The CT scan, abdominal CT scan is not useful really in the benign biliary tree pathologies. However, it's useful when you suspect carcinoma of the gallbladder and when you suspect issues of intermittent jaundice, because some of the causes of intermittent jaundice are periampullary tumors. Okay, then lymphomas. All right, so here in reaching out or throwing out those differential diagnoses. Gallstones are not usually clearly visualized using CT scan, and cholecystitis is usually underdiagnosed using that tomography, computed tomography. And the drawback is that it has high dose of radiation. This is magic of CT scan showing the gallbladder cancer here. Okay. Let's move forward. ARCP. More interrogative than diagnostic biliary tree evaluation. It has actually revolutionized the evaluations and management of common bile ducts. Is the gold standard of imaging of the biliary tree. It detects stones or malignant strictures. It identifies the cause and the level of obstruction. It's also good to know that these particular investigations, all right, can be used really in any patient that comes with common bile duct stones. You can use that ERCP to extract the stone and relieve the symptoms of jaundice in such a patient. And you give them 4 to 6 weeks, then you come back for interval cholecystectomy. That is one pathology aside appendicitis, where you will now come back for an interval surgery. That's the picture showing the endoscopic retrograde cholangiopancreatography. That is it. Let's not waste our time. This is the percutaneous cholangiography. Sorry. The percutaneous transhepatic cholangiography is more of a palliative technique. The bile ducts are cannulated directly, demonstrate areas of strictures or obstructions, effective in patients with a dilated biliary ductal system. The indications for using PTC are where the ERCP fails or is not possible for use. Then the PTC is used for stenting of the biliary tree, and also prior to biliary drainage procedures, you can use the PTC. And even in patients that are not fit for surgery, you can use PTC as the drainage procedure to relieve symptoms of obstruction within the common bile duct or within the biliary tree in general. The contraindications are as follows: bleeding tendencies, patient that is unfit for surgery, and co. Food blood counts, these are some of the investigations. Food blood counts and differentials with erythrocyte sedimentation rate. Here in the food blood count, you may see neutrophilia because of that obstruction in the common bile ducts, in the biliary tree. The obstruction in the biliary tree generates or leads to stasis of bile within the system. And in any situation where there's stasis within the biliary tree, that's predisposes the patient to having bacteremia and subsequently sepsis developing and subsequent ascending cholangitis. Okay. Then in the differentials, all right, if you can remember, we talked about stool microscopy. When you do full blood count and you have eosinophilia, that points to you that there's really either an allergy or parasitic infestation here. So once you see eosinophilia, you know that, fine, there's something happening. Let's do something. And all you need to do in the surgical jaundice patient with ascaris lumbricoides to give antihelminthes. That is why we say surgical jaundice. That means this is jaundice that may or may not be amenable to surgery. In instance of obstruction in the biliary tree from the helminthes, that will suffice. Serum urine electrolyte with creatinine, random blood sugar, serum protein, and coagulation profile, very important. You know, in the jaundice patient, there is coagulopathy. We say more like a consumptive coagulopathy because there's deficiency of the protein factor 2, 7, 9, and 10. And this may predispose the patient to developing or having hemorrhage during surgery. So very important to know, because even in the pre-operative period, one can take some critical decision in averting evidence of or in averting the occurrence of hemorrhage in such patient. Pre-operatively, it's good to know that there are challenges in managing a jaundice patient, and of course, a patient that presents with cholelithiasis, usually present with these challenges of jaundice, such as the common challenges that pose a challenge to the surgeon are hemorrhage, infection, and the hepatorenal syndrome. So preoperatively, we take measures to correct this. In the hemorrhage, part of what we do is that the first contact of such a patient with the surgeon, we start such patients on hematinics to try to build them up. Okay, then of course, if you are in a center where you will have those fractions of those floating factor 2, 7, 9, and 10, you can infuse it to the patient. But however, in our environment, what do we do? In such patients, what we do is we start them on supplemental vitamin K, which is given 10 milligram daily before, at least 5 days before the date of surgery. And then we group and cross-match fresh whole blood. Fresh whole blood, of course, we know what the definition of fresh whole blood is. So infection, of course, we know that once there's biliary obstruction, there's stasis within, and of course, which will precipitate bacteremia and onward infection within the tree, that's cholangitis. As such, we give, once we see such a patient, we give presumptive antibiotic therapy. Then the hepatorenal syndrome, of course. In hepatorenal syndrome here, what happens is that the toxic bile pigments causes acute tubular necrosis. And if nothing is done, that can lead to renal failure in such patients. What do we do in the preoperative period to avert hepatorenal syndrome from happening? We ensure that this patient is preloaded, adequately hydrated, at least 3.5 to 4 liters of fluid every 24 hours prior to surgery. And the patient has to make an adequate urinary output. In fact, for adults, we know 0.5 to 1, but we aim at the upper limit of the normal urinary output. We obtain consent here while preparing for the surgery. Consent with regards to such a patient should even include the fact that this patient can die following that surgery, that's intraoperatively, okay, because it's something that may happen. So we prepare our patient's mind, tell them all the modalities of management of stones in the common bile duct, all the modalities that are available, and the modalities of treatment that are available within our own environment, and the number of patients that we've done such surgeries to. And if possible, we may even link such a patient to one of the survivors of the common bile duct surgery to rub minds with the patient that's preparing for such surgeries. So informed consent, very, very important, very vital in the surgical management of cholelithiasis. Patient is, however, booked for open cholecystectomy plus common bile duct exploration. However, we know that another option to this is laparoscopic cholecystectomy with laparoscopic common bile duct exploration if we have facilities such as the choledoscope. Anesthetic review, very important to ascertain patient's fitness for the surgery. Surgery is usually carried out under general anesthesia with relaxant technique. Routine cleaning and draping done under aseptic method. Then the access to this surgery we'll discuss. Before we go to the access to surgery, it's important to know this surgical anatomy of the biliary tree or the common bile duct. The common bile duct very important aspect of the biliary tree that warranted this discussion because of the obstruction of the stone within the common bile ducts. It's good to know that the entire biliary tree, as shown here, starts from the biliary canaliculi within the liver, which correlates to the interlobular ducts that now give rise to the hepatic ducts. That's both the right and the left hepatic duct that now merges to the common hepatic, which crosses down and then joined by the cystic duct. At this level, it becomes the common bile duct, which crosses down to the posterior aspect of the duodenum and emerges and enters the second part of the duodenum via the ampulla of Vater, together with the pancreatic duct of Wilson and Santorini, as the case may be. It's good to know that you can do common bile duct exploration without actually taking care of the reservoir of stones. That's the gallbladder. So that's, in essence, that is why we do cholecystectomy in common bile duct exploration for stones. However, it's also good to know that the common bile duct is on the anteromedial aspect of the duodenum. And so also in doing this surgery, it's also good to know about the triangle of Callot. The triangle of Callot is where you visualize there's a triangle that makes it easy, really, to do the cholecystectomy. Because in cholecystectomy, of course, you know, you have to take care of the cystic artery within the triangle of Callot. This is bounded by the on the right, on the left by the common hepatic ducts, then laterally the cystic duct, and then the base is the inferior margin of the liver. So within this, the branch of the right hepatic artery, which is the cystic duct, crosses there. We'll see it in due course. It's good to know that the common bile duct has a length of 7 to 11 centimeters. Okay, and on the average is about 6 to 8 centimeters in diameter. However, as it crosses distally to the entrance at the ampulla of Vater, it narrows. It narrows up to about occasionally, in some individuals, 3 to 4 millimeters in diameter. And that's the more reason why stones that are big in caliber tends to get obstructed. Okay, so after the anesthesia, choice of incision or choice of exposure into doing the biliary tree exploration. Here you can have the subcostal or coccus incision. That's there. You can have a more cosmetic transverse incision, and then the midline. However, since we're doing exploratory laparotomy, in this case, more especially in our center, we favor the midline approach to common bile duct exploration. Okay. The exposure, how is this exposure done? The liver using the device. That's the device. You put an abdominal pack over the liver so as to avoid injury to the liver. Then you need 2 assistants here. Okay. Then the surgeon will stay on the left side of left-hand side of the patient to give him good exposure for his dissection. The liver is retracted superiorly and laterally to open up the gallbladder. Then from here, you put the abdopack using either the divas, or any of the abdominal retractors. You retract the transverse column inferiorly and downwards. Then you reflect alongside. You reflect the laser curvature of the stomach alongside part of the duodenum, okay, towards the lateral aspect. This opens up you have a good exposure for the diagnosis. What we do for the surgery, what we do first is cholecystectomy. And in cholecystectomy, we use the fundus first approach. The fundus first approach means you go through dissecting the gallbladder from the hepatic bed, that's on the right lobe of the liver, using blunt, initially sharp dissection, using your Mayo's scissors. Then you start dissecting bluntly with the aid of Leahy's swabs. The Leahy swab enables blunt dissection until you now demonstrate the cystic duct. This is the cystic duct. Okay? Before you go on to mobilize the cystic duct, okay, this is still demonstrating what we do when we're doing the common bile duct exploration with first cholecystectomy. The cystic artery is clamped, then doubly ligated in continuity, two ligations on the proximal aspect of the cystic artery, then one on the distal aspect of the cystic artery. So also doubly ligation of the cystic duct is done. Here is equally good to know that there are some aberrations in some patients. Some of the patients may have a very long cystic duct, okay, for which when you amputate the cystic duct, leaving remnant of the cystic duct that may harbor some stones. This will lead to a syndrome called post-cholecystectomy syndrome. The patient may manifest with clinical evidence of cholelithiasis, even though the patient has had cholecystectomy being done. So it's good to take note of those kind of aberrations. Then occasionally, the cystic duct may be so short that it may be difficult to really differentiate it from the hepatic duct. And in other occasions, the cystic duct may just arise directly on the common bile duct. So it's good to know this before you go and ligate the entire cystic duct, and you end up with heterogenic biliary blockage, which will not be good for our patients. However, this decision to explore the common bile duct rests on the following: demonstration of stones on the preoperative magnetic resonance cholangiopancreatography, or operative cholangiogram, or palpation. However, it's good to know that in our environment, that we don't even have the CT, talk less CT scan, to talk less of, even though the CT scan is on its way, talk more of magnetic resonance cholangiopancreatography. So we rely more on the palpation method. We palpate the common bile ducts for the evidence of the stones within the biliary tree. In the common bile duct exploration, you first of all have to put stair switches after identifying the common bile duct following cholecystectomy. These are the stair switches. You make your incision using either size 10 or 15 blades. You make a longitudinal incision as shown here. These stair switches are held up with some level of gentle traction by the two assistants while the surgeon makes that longitudinal incision. After making that longitudinal incision and extraction of the stones, we tend to close this incision transversely. You make a longitudinal incision, you close transversely to give some room of increase in diameter of that common bile duct. So this is what happened. We usually use this forceps, which is called the Jardine forceps, for extraction of our stones in the common bile ducts. And after extraction of these stones, we may, if we have the T-tube, we can insert the T-tube, which will aid us in the immediate post-operative cholangiography to actually demonstrate that the stones are cleared completely within the common bile duct. However, in our environment, really, we don't have that benefit of inserting the T-tube. But what do? You will see it in due course. Okay, this is irrigation of the common bile duct using syringe. We'll see what we do in our center. This is what we do. We use the feeding tube. Sorry, I'm trying to use cursor. That's the feeding tube. We use size 6 or 8, depending on the diameter of the common bile duct you have. This is our longitudinal incision. It's still there. After extraction of the stones, we need to clear some of the stones that are not really impacted, but they are still within the common bile duct. This is it. So this is the feeding tube. We pass it through that incision. Just passing it through that incision may further push some of the small common bile duct stones to come out through the jejunum, okay, so that you get rid of them. Then you flush the entire common bile duct with normal saline. That's what we do to avert that. That's to show the gallbladder after cholecystectomy and the stones. This stone is the one that's impacted because of its diameter. These other smaller stones happen to come out via the incision that we made. But however, some of them that didn't come out were flushed through the duodenum, the intestine. It's good to know that in laparoscopic common bile duct exploration, which is currently practiced worldwide. However, we are limited because we don't have the facility for laparoscopic surgery or minimal access surgery. This is the colonoscope, okay, for doing your endoscopic sphincterotomy and extraction of the stones. This showing the retrieval of the stones in the biliary tree. I've said this before. Stones that are impacted in the ampulla may be difficult for both endoscopic ductal clearance, that's open for the endoscopic ductal clearance, and open common bile duct exploration. So it may be difficult to extract them. In these cases, we adopt the drainage procedure. That's the transduodenal sphincteroplasty and stone extraction, which is usually performed. If this is not successful, you may do choledochoduodenostomy or Roux-en-Y. That's the bypass surgery. You bypass the stone by anastomosing the common bile duct with the duodenum. But this is not without issues. We'll see what really happened. Or you can do a hepatico-duodenostomy. Thus, you anastomose the common hepatic duct to the duodenum. This is to allow continuity of bile. Okay, having seen that bile is important in physiology of fats, that's fat digestion. The SOM syndrome is actually associated with the choledochoduodenostomy, as we can now describe later. This is what happens when you have stones that are impacted, okay, apparently impacted in the distal aspect of the common bile duct, that makes it difficult for both open and endoscopic extraction. So you anastomose the common hepatic duct, the more of the proximal aspects of the common hepatic duct with the duodenum. This is what happens. But however, the proximal aspects of that anastomosis, more on the part of the biliary tree, that's the common bile duct. In this area, this seems to be like an area of stasis of bile after this kind of surgery. And of course, you know that once there's stasis within the biliary tree, the next thing that will happen is bacteremia. And once that there's bacteremia, infection sets in, and the patient may present with signs of ascending cholangitis. That results in the SOM syndrome seen. This is just to show us that laparoscopic common bile duct exploration with the aid of a cholelithoscope is possible. We are getting there in a short distant time. What actually results to complications or make complications more with regard to surgery within the biliary tree, especially doing common bile ducts exploration, related to dangerous anatomy and the pathology, that is whether acute or chronic inflammation. In chronic inflammation, of course, you know there will be a lot of adhesions that you may need to do adhesiolysis around that callus triangle area, and this may lead to inadvertent injury to structures around that size, with increasing risks of complications arising. Okay, and that may even lead to more chances of bleeding around that area, obscuring the exposure to those structures, with the risk of injury to both the common bile ducts and other structures around that site. Other things of importance to note is inadequate experience or insufficient experience of the surgeon with regards to the common bile duct exploration. That will lead to more injuries here. However, it's what to note that in situations where the cystic artery is injured, the a maneuver can be done. You block or apply pressure on the right hepatic artery, which will reduce bleeding from the cystic duct, and it will give room for visualization of the cystic duct to be ligated. These are some of the post-operative complications of open common bile duct surgery. Prognosis is usually good. In conclusion, despite limitations in diagnostic and therapeutic equipments with regard to common bile ducts exploration, great have been achieved, but it will have been greater. Thank you.
Yes, thank you, Dr. Marwa, for this excellent, elaborate, and educative presentation. Looking at the images and your presentation, it looks so scary to actually have this kind of condition in our environment based on those challenges we highlight, the difficulties, in terms of equipments and whatever thing to make the diagnosis and help even during surgical process. Thank you for bringing this. Despite the challenges, we concluded that great successes have been achieved, and that is the spirit of the Nigerian doctor, to be able to do great things even in the midst of limited resources. So thank you once more. I think, okay, let's go to the question. Okay. Yeah, so this one's so interesting and educative. Yeah, then say, what are the challenges in management during pregnancy? Those with common bile duct stone that need surgery, what are their complications during surgery or during pregnancy? If you want to speak and raise your virtual hand so that we can recognize you to talk.
I think we may take those questions, then respond to them, or I should go ahead and start responding to the questions as they come. Okay, the challenges in pregnancy actually with a patient that has the common bile duct stones is immense, but this has to do with the stage of pregnancy. If the patient is at the later stage, almost close to term, you may allow the woman to deliver, give some palliative measures, antibiotics that are palatable, that are allowed in the patient with pregnancy. Then, of course, you have to take charge of some of the challenges of a jaundice patient, which may manifest itself even during the delivery period of these patients. If we are in a setting where we can have laparoscopic, our scope here is wide, even though we set open common bile duct exploration, but it's good to know that the common bile duct exploration can be done laparoscopically. In early pregnancy, we may explore the common bile duct with the aid of collaboration with the gynecologist, which will now stabilize this pregnancy. And we all know that laparoscopic surgery is minimal access, so we can actually do that. And it's also good to know that there's an advancement now called the scarless surgery. That you pass your endoscope via the natural orifices without any scar. Okay, so minimal handling of structures will now allow the common bile duct exploration done laparoscopically, and we may get good results. So we may adopt those measures, but as I say, once the pregnancy is getting to term, we may decide to wait till we deliver such patients. But however, if the complications of this jaundice patient by having the stone impacted in the common bile duct has formed a risk to this patient, you may ask for the opinion of the gynecologist to either abort that pregnancy, which is early, then you subsequently go on and offer that patient common bile duct exploration with extraction of these stones. And it's good to know also that some of these stones are actually like an incidental finding in the diagnosis of the common bile duct. You may have a woman that is pregnant and have you make a diagnosis of stone within the common bile duct that incidentally means that it's asymptomatic. So of course you don't do anything for during that period. You allow things to go on. Some of these stones of small diameter can actually move down and enter through the common bile duct to the duodenum, and without causing any problem. But however, if you make that incidental, I'm jumping to another thing. If you make that incidental diagnosis of common bile duct stones, or even stone, or let's say cholelithiasis, there is asymptomatic. Now you can actually give what we call busol leaf. This is a drug. The busol leaf is a drug that has the ability to dissolve stones that are less than 5 to 10 centimeters in diameter. But you take it for a long period of at least 3 to 4 weeks to give you that effect. Some of the stones may go, may get dissolved during that period. It's also good to know that we have various stones. We have the cholesterol types of stones, which even if you make the diagnosis, they may not grow up to that level. Okay, we call them solitaire. They may not grow up to that level to cause obstructions within the common bile duct. They will just go down and then get dislodged into the small intestine. And also you should know that we have also biliary stones, which may subsequently cause what we call ileus. That's gallbladder ileus or gallbladder stone ileus to most of the patients, but not really causing obstruction within the biliary tree. But the stones that are common in our environment and are said to cause more issues are the mixed stones. Thank you. I think we've done justice, maybe.
All right, thank you. I don't know. Okay, let's still go. All right, this one's an excellent presentation. Excellent presentation. Are there risk factors for biliary stones, such as foods, drugs, or behaviors? That's a nice presentation. Particularly nice that you showed indigenous images from your practice. And this one is a question too. How does bile stone differ from bile cyst at presentation in resource poor setting where there's no radiological imaging? Okay, so maybe after that we conclude on this and take the next presentation.
Thank you very much for those questions. The risk factors for stones. Let me throw our mind back to those periods in medical school for the 5F. Okay, that is a female, fertile, fat. Ladies don't want to hear that. At 40. Okay, these are some of the risk factors that predispose to stone formation. So also hemoglobinopathies, especially when we are in the tropics, and hemoglobinopathies is something that is of concern, and of course something that play a key role in the etiopathogenesis of these stones. Okay, our eating habits also, we tend to adopt more of European or Caucasian way of eating. Okay, so that also poses the risks of developing common bile ducts or just generally stones within the biliary tree. Okay, the next question with regards to stones in the biliary tree, and then what? Cysts within the biliary tree. Okay, stones really and cysts in the biliary tree, even with no facilities for diagnosis. Symptomatically, the stones usually present with colicky pain, especially if they're within the gallbladder, and then they move towards the Hartmann's pouch and tends to cause obstruction within that cystic duct. If you have such, okay, the patient may present with colicky abdominal pain. And for the fact that there's obstruction of the cystic duct, it means that there's stasis within the gallbladder. Of course, that means that there's bacteremia and then infection. Of course, which means that there's cholecystitis. Here, that means calculus cholecystitis. Okay, so with that, if a patient takes fatty meal, and we know what happens if somebody takes fatty meal, and when the meal goes up to that duodenum, okay, with cholecystokinin being released in response, that will cause contraction of an already inflamed gallbladder, okay, and then also relaxation of the sphincter of body for contraction of the bile ducts, the gallbladder, secretion of the bile through the common bile duct to the duodenum. Already, because of that, you will have that colicky pain because the contraction is on an inflamed gallbladder that may cause that colicky pain to happen. That may not be the picture in the biliary cyst, unless the biliary cyst has grown up so large, okay, to cause obstruction within the tree. And of course, here, what you will see is evidence, clinical evidence of surgical jaundice. Thank you.
Okay. Hello, Dr. Kanta's hand is up. You want to ask a question? So, Dr. Kanta, please go ahead.
Thank you very much, the chairman. I commend the presenter, Dr. Marwa. It was a very lovely presentation. You know, concerning pregnancy, I think the warning is this. Please, if you see a pregnant woman with the right hypochondrial pains or jaundice, it's better to refer, because management is multidisciplinary. Obstetrician, the surgeon, and pediatricians, and even the physicians will be involved. But if you see a pregnant woman may not have abdominal pains, jaundice, there is what is called intrahepatic cholestasis of the pregnancy. And then usually they present with itching, usually on the palms and on the soles. It's not usually a problem with the mother. It is a baby that will suffer because of the increased level of bile salts in the blood. And some of them may die if the intervention didn't get intervention at time, usually in the second or third trimester. It's better to refer them. And then some of them may go into preterm labor. Just like Dr. Marwa said, the main challenges in the management is lack of laparoscopic facilities, because in the developed world, even pregnant women and with the bile stones, especially the obstructed one, they can be operated at any point in time. But here, if it's a serious problem, the gynae can deliver the baby and hand over the mother to the surgeons. So I think these are just things we need to note. And then some of these women may be jaundice, right hypochondrial pain. They may have even more serious problem. If you have heard of HERP syndrome, those with a severe preeclampsia. So I think the lesson here is better to refer them early to facilities that can manage them to avoid unnecessary mortality or morbidity. Thank you very much.
Thank you for that's why is very important. That's why we are working in a tertiary health institution. Okay? Thank you so much.
Okay, thank you, Dr. Marwa, for the brilliant presentation. I hope we've learned, we've refreshed our memories, we've learned new things, and we'll be educated. I want to thank you once again, Dr. Marwa, for taking your time to educate us and to do this presentation for us. Thank you. So we'll take the next presentation. The next presentation is going to be taken by Dr. Zara. By Dr. Zara Bala. She's a radiologist working with Federal Medical Center, Jalingo. She's going to take us through what's the topic? What? Okay, yeah, so basic interpretations, looking at chest radiograph. How do we interpret science, on our chest radiograph in clinical practice? So she's going to guide us and teach us in this presentation. Dr. Zara, I don't know if you're on.
Okay, I'm around, sir. Good morning.
Okay, thank you very much.
Okay, so good morning, everybody. It's nice having everyone around. My name is Dr. Zara Bala. I'm from Radiology Department of Federal Medical Center, Jalingo. So this morning, I'm going to take a very short and brief presentation titled The Basic Interpretation of Chest Radiographic Findings based on the few, I'll just pick some few, not necessarily the signs of the chest radiograph, because I think the signs may be a little bit more difficult. So the essence of this presentation is for everyone to just know the difference between a normal and an abnormal radiograph, so that anytime you request for one and you take a look at the radiograph, you also should have a little impression as to what is on the radiograph even before you get your report, so as to help in the management of your patients. So the outline is such that I'm going to give a brief introduction, just tell you about some of the projections, what we consider as radiologists, some technical factors, just show you some hidden areas in the chest where you need to look at. And then some disease entities, I think 5 of them, the most common disease entities that we tend to encounter, so that you can have a knowledge of what they look like on the chest radiograph. And then various treatment options that are available and the conclusion. I hope I'm audible. Hello?
Yes, you're audible. We can hear you.
Okay, I'm audible, right?
Yes.
Dr. Bright, my slides are not moving. Okay. Good. So I think we're on the same page now, right? Okay. So a chest radiograph is basically a radiological investigation that is used to examine the chest. Okay, you look at the heart, you look at the lung fields, you look at the bony rib cage, okay, and other structures that are in the chest. And then it's the most common radiograph that is usually taken in medicine, and it has a wide range of clinical indications. Okay, and then it's usually performed when the risks actually outweighs the benefits, because it uses radiation for it to be performed. So you have to take note of that. It's not just sending somebody, go and do chest x-ray, go and do chest x-ray. Actually, there has to be indication for it. And then the risks has to outweigh the benefit has to outweigh the risks that is involved. So we have different projections for chest x-ray. Okay, we have the PA view, the AP view. You can do a lateral depending on the indication, depending on what you see. You can do a lateral decubitus radiograph, okay, just to see if there are changes, like when you have fluid, okay, does it change in location? Does it change in appearance? Okay. You can do a lordotic view, apical view to check the apexes. You can do expiratory views, okay, when you suspect that the patient may have some features of air trapping. Okay, you can do oblique views, modified views, depending on what you would want to see. You can examine the ribs, you can examine the sternum. So there are many views actually, but the main one that we do is the PA chest radiograph. So there are some technical factors that you need to look at when you're looking at a particular radiograph. You have to identify, okay, you have to be sure that is the patient's radiograph, the patient's name, you have to check the number, you have to check the date, okay, and if possible, the time that it has been taken. You have to know the projection. Is it an AP or a PA radiograph? I said that most of the radiographs that we do are PA. However, in some cases, you may have critically ill patients that may not be able to position themselves very well. So you can do the AP, okay? You can also, it's usually done erect, but sometimes if the patient is critically ill, or if there's an indication for a supine radiograph, probably there's something you want to also demonstrate, you can do that. You have to make sure that the inspiratory effort of the patient is adequate, because if the inspiratory effort of the patient is not adequate, you can have errors in interpreting x-rays. That's why you see sometimes we say poor inspiratory effort, repeat this particular x-ray, and you have to make sure that the x-ray is okay, because sometimes it can be overexposed, it can be underexposed, the patient may be rotated. But by and large, the technical factors that are taken into consideration are factors that ensure the accuracy, okay, of the report of a particular patient. So this is basically the next slide, please, Dr. Bright. Okay, so this is basically a normal chest radiograph, okay, demonstrating the heart. I'm sure we all know how the heart shadow looks like, okay, demonstrating the lung fields, the chest wall, the diaphragm, and other structures of the chest. So this is actually what a normal chest x-ray looks like. So we describe x-rays in forms of densities, okay. So the darkest, which is the lucency, is the air, okay. And then you tend to get various opacities of soft tissue densities in various degrees. Then you have the one of calcific density, which is the bone, okay? So, sorry, there's a mix-up there. That's supposed to be upper lung lobes, please, not zones. Sorry about that. Okay, so sometimes in interpreting chest x-rays, you have to, on the frontal projections, you divide the chest radiographs into the lung fields into 3, okay, so that you can just have an imaginary, just draw an imaginary line, divide it into 3: upper lung zone, middle lung zone, and then lower lung zones, so as to describe the various disease processes that occurs in the chest, because some chest conditions tend to have predilection for particular parts of the chest, okay? So that radiograph is just trying to show you the different lobes of the lung fields. When you see a disease condition in the upper lung field, then you just do a lateral lung field to demonstrate better where that particular lesion is. And also there are some hidden areas in the chest that you have to look out for anytime you request for a chest radiograph, whether you have a report or not. You have to look at the apex of the lungs, you have to look at the diaphragm, you have to look at the costophrenic angles, you have to look at the cardiophrenic angles, you have to look at the heart borders, you have to look at the retrocardiac areas, okay? So these are, and also the chest wall. So all these are hidden areas that you have to look out while evaluating a chest radiograph personally, so that you can have an overview of whatsoever the disease process is in the chest. So the common disease entities I've personally encountered during my short time of practice here are basically various types of chest infections, congestive cardiac failure. Most indications come as trauma to the chest, and then some people are being suspected to have COPD, and then another very common disease entity is metastatic chest disease. So chest infection actually has some different causes, okay, as we all know on a chest radiograph, and it has different types of manifestations on the chest radiographs. So this chest infection sometimes is even upper respiratory tract infection or lower respiratory tract infection, but from the little clinical practice I've gathered, I think most of the indications that we have are more like from the lower respiratory tract infections. Okay, but the upper respiratory tract infections too, there are different radiological investigations that can be done to demonstrate, like acute epiglottitis and then laryngotracheal bronchitis, where you have the stipple sign and the thumb sign and all of that. But I think most of the most of the indications we've had so far in the department are more of lower respiratory tract infection, and it's more in adults than children. Most of the ones that come from children are most bronchopneumonia, where you have increased pulmonary vasculation with some nodular shadows, and then in TB. And then other types of infections, most of the ones that we've seen are various types of consolidations in various ranges. Okay, you can have lung collapse, lung abscess, pleural collection, empyema thoracis, okay, extending to empyema necessitans pneumothorax. Okay, you can have various types of lymphadenopathy. So these are cone down views. Okay, the first three images are cone down views. Okay, can I have the next slide? 11. Sorry, I hope I'm not too fast. Hello? Hello?
No, you are not. You are not. Go ahead. We're listening.
Okay. So this slide is just trying to demonstrate, okay, various types of opacities that we see regarding chest infection, not only limited to chest infection, but other disease processes, okay? So the first one, you see some linear opacities of soft tissue density, okay? The second one, you see some reticular opacities, while the third one, you see a blend of both the reticular and linear opacities of soft tissue density, while the lower images, you get to find more dense opacities of soft tissue density, okay, with some tubular branching and patterns and bat wing appearance, and that is what we usually call the alveolar edema in some patients that have very severe, okay, chest infections. Okay, so the next slide is a frontal chest radiograph demonstrating a dense homogeneous, fairly homogeneous opacity of soft tissue density projected in the upper lung zone, bounded inferiorly by the transverse fissure with some linear lucencies within it that may be suggestive of air bronchogram of sign. So these are features that we see in consolidative changes. Consolidative changes occurs not only in chest infection, but in a wide range of other causes. So the clinical history and then the examination findings are, and with lab results, are what is likely to give you a pointer as to what the disease process is. So this type of changes can occur in various parts of the lungs. You can see it in the left lower lung zone, okay, on the first radiograph, okay, and you can see it around the lingular lobe in the second radiograph, okay. Next slide, doctor. Okay, in the second radiograph. So this is just to demonstrate that there are various lung zones, okay, that this particular infective processes can occur. So sometimes you see them, you may do a lateral view, like I said earlier, so that you can demonstrate, okay, exactly where it is, just in case it's not very, very clear. Another chest findings that we tend to have are lymphadenopathies in the chest, as demonstrated in this chest X-ray, where you have bilateral but asymmetrical dense homogeneous opacities of soft tissue densities projected in the region of the hilum, okay, obscuring the hilar point. Okay, they are asymmetrical, but they are bilateral. Okay, the right paratracheal strip is also appears thickened. Okay, so that's how sometimes you get to see lymph nodes in the chest. Some may have calcific degenerative changes, and some may necessarily not have calcific degenerative changes. Some may even have cystic degenerative changes, depending on what you get to see on the radiograph. Okay, so worthy of note is a type of disease processed chest infection that is caused by Klebsiella pneumonia, where you have the bulging fissure sign, okay, where you have a dense homogeneous opacity of soft tissue density with bulging, okay, of the fissure sign because of the exudates that tend to occur in the disease process. Okay, so that is what is being demonstrated on the 15th slide. Okay, Dr. Bright, I think I'm faster than you. Hello?
Well, with you, Chief.
Okay, or is it my own network that is slow? Okay, so I'm on slide 16. Okay, so let me carry on. Like I said, okay, other disease processes that you can find, other radiographic features that you can find is in cases of lung collapse and pleural collection. Okay, so this first radiograph demonstrates a lung collapse, evidenced by a fairly homogeneous opacity of soft tissue density obscuring the entire right hemithorax, okay, with associated rib crowding. Okay, there's ill definition of the diaphragm, the heart borders, the cardiophrenic angles. You can see the mediastinal structures being pulled to that ipsilateral side with oversight of rib crowding. So these are features that you get to see in patients that have lung collapse. Okay, in others, you can have pleural collection as seen on the second radiograph, okay, which is also a homogeneous opacity of soft tissue density. You can see flaring of the ribs. You can see these opacities completely obscuring the heart borders, the costophrenic sulci, cardiophrenic sulci, the diaphragm, extending all the way to the apex, okay? And, you know, pushing the mediastinum to the contralateral side. Okay, so other features that you get to see is deep sulcus sign in patients that have pneumothorax, especially in patients that have on supine radiograph, where you have an abnormal lucency and deepening of one of the unilateral costophrenic sulcus, as indicated by the yellow arrow in this particular radiograph. Okay, other features that you get to see is pleural collections. Okay, this is a frontal chest radiograph of a patient that has homogeneous opacity of soft tissue density in the left middle and lower lung zone, obscuring the heart border, cardiophrenic, so costophrenic sulci, the diaphragm extending to the lateral chest wall with an upper meniscus sign. Okay, so depending on the amount of fluid collection that you have in the pleural space, you can see that this is quite much, and then the meniscus sign is demonstrated at the upper part of the collection. So the pleural collection, it can be free, you know, it can be loculated when you have maybe some bands of adhesions like that within the pleural cavity. Okay, so like this one, a homogeneous opacity of soft tissue density, okay, attached to the lateral chest wall. You can see that it's broad-based, okay, convex outer margin, okay, and then you can see that it's obscuring the costophrenic, the costophrenic sulcus. However, it does not extend up superiorly down up to the apex or to the upper parts of the lungs, as we expect, okay, in free fluid collection. Okay, so this is more like a trapped type of fluid loculated collection. Another type that of pleural collection that you can have is subpulmonic, okay, pleural collection, as demonstrated in this particular radiograph, where you can see that there's an abnormal elevation of the right hemidiaphragm. Okay, So sometimes when you see patients like this, you have to scan them, just put a probe and then see what is happening in that particular part of the lung fields. You can also see that the right middle lung zone is not clear. There are some opacities of soft tissue densities, comprising of both reticular and nodular opacities of soft tissue densities, but other parts of the lung fields are unremarkable. So another type of abnormality that you get to find are cavitatory lesions. Some may have air fluid levels, some may not. Okay, like in this particular patient, okay, you can see that thick-walled, irregular, huge cavitatory lesion projected on the left middle lung zone, surrounded by reticular as well as nodular opacities of soft tissue densities that are coalescing to form larger patches. Okay, and then you can see also that the right lung field, okay, the right middle lung field also is not clear. There are some reticulations there, and the transverse fissure, okay, is also taken. Okay, so these are the kind of features that you get to see in patients that have various types of chest infection. So another very common disease condition that occurs is patients' congestive cardiac failure. Okay, and then the features you get to see on chest radiographs are that of pulmonary venous, depending on the stage actually. The first stage, you may just have cardiomegaly and then redistribution of blood flow, okay, where you have more of the superior vessels being engorged, okay. Then you tend to have, as it progresses, as the venous congestion progresses, okay, you get to have Kerry A lines, Kerry B lines, and all of that. And then you can have the complete bat winging, interstitial edema, pleural collection, and others towards the last stage of the cardiac failure. So I am sure we all know how to measure the cardiothoracic volume. I think this one is basic, the maximum diameter of the heart to that of the thoracic ratio, upper limit 50 in adults, allowing for some technical factors, okay, and then for children, upper limit also 60, allowing for some technical factors, okay. So you can see that this next image is displaying an enlarged heart, okay, and then straightening of the left heart border. Okay, this was seen in a patient that had cardiomegaly, okay. And then the next image is yes, in an image demonstrating congestive cardiac failure, evidenced by cardiomegaly of left ventricular preponderance. You can see that the aorta is unfolded. You can see features of upper lobe diversion, evidenced by increased prominence of the upper pulmonary vasculature. The postophrenic sources are actually free. The bony rib cage is unremarkable. You can see some short Kerry lines adjacent the chest wall on the right right and left lung bases. So these were features that were seen in a patient that had congestive cardiac failure. Okay, so trauma is also another common disease condition that you get to see, okay, among patients. And then what you get to see on their radiographs are more of contusions, lacerations, okay, hematoma collection. Some may have some features of like aspiration pneumonia after a while. Then some patients may have features of pulmonary edema or acute respiratory distress syndrome, and some may have fat embolism, okay. So these were radiographs of a patient that had trauma. Look at the first radiograph, the posterior rib. From the 5th to 7th rib, you can see an area of complete cortical discontinuity with displacement of the fractured segments. These were features that were found in a patient that had trauma. And if you look at this view of the sternum too, okay, the next image, you're going to see an area of cortical discontinuity in the sternum. Okay, this was also found in a patient that had trauma. Okay, so some trauma patients also come with features of pneumothorax, and pneumothorax is usually demonstrated on a plain radiograph. Apart from the deep sign I told you, there's an area of hypertransradiancy, okay, that seems to be devoid of lung markings. In this particular radiograph, you can see a thin wall medially, okay, that represents a pleural line, okay, and you can see the collapsed lung just adjacent to the heart border. So this was a patient that had pneumothorax as a result of trauma. Like I said earlier, you can have pleural collections too in a patient that had trauma, and then most of the times these are hematoma collections that can be drained, okay? And then the patients can also have pulmonary congestion, pulmonary contusions, okay, which are also seen as various degrees of homogeneous opacity of some tissue density projected in the lung phase, which may or may not have the air bronchogram sign, as I earlier stated. Okay, so this is a radiograph of a patient, okay, that had trauma demonstrating a tension pneumothorax evidenced by flattening of the right hemidiaphragm, okay. You can see that the entire right lung field is hypertransradiant. You can see the mediastinal structures, pushed to the contralateral side, which is the left. You can see that they are rib flaring. Okay, the intercostal spaces are wider on this particular part that has this particular disease condition. So when you see this type of disease condition displacing the heart or other mediastinal structures to the contralateral side, it's a warning sign, okay, that this patient has a certain degree of tension, pneumothorax, okay? So this is also a plain radiograph demonstrating homogeneous opacity of soft tissue density in the entire left lung field, okay? Dividedly displacing the heart to the contralateral side, okay? You can see that it's pushing the heart, okay? So this is also a red flag sign, because you would have to drain whatsoever collection that is inside to save the mediastinum and its structures from further damage, okay? So another common disease condition is COPD, okay? Some patients may have cardiomegaly, some may have small heart, some may have emphysematous changes evidenced by hyperinflation. You can see flattened diaphragm, barrel, chest, widened ribs, increased retrosternal space, okay? Depending if complications has already setting in, you can have features of heart failure, you can have features of pulmonary hypertension with pruning of the vessels, okay? The COPD is actually a spectrum, okay, where you have all those, is it pink puffers and big blue bloaters and, all of that, where you have all those chronic bronchitis, asthma, emphysematous changes and all of that. So it's actually quite a range, okay? So the radiographs can actually be normal, and then it can also be abnormal, most especially in patients that have chronic bronchitis. You are going to have features of finger and glove appearance, as demonstrated by linear tubular homogeneous opacities of soft tissue density in this particular radiograph, particularly in the upper lung fields. Okay, you can see that the hard borders are a bit not clear. Okay, they're a bit shabby and hard borders. Okay, so these were features that were found in a patient that had chronic bronchitis as a form of a COPD. Okay, so some of them that have emphysematous changes, okay, we can have hypertransradiancy as demonstrated on this particular radiograph. Okay, flattening of the diaphragm when you measure from the cardiophrenic to the costophrenic angle, any measurement less than 1.5, okay, we say the diaphragm is flattened, okay. You can see that the intercostal spaces are widened. You can see increased retrosternal space on the second radiograph. So also you can see that there are a lot of features of hyperinflation. So this was seen in a patient that had COPD. Okay, so another very common disease condition is metastatic chest disease. The chest is not exempted from metastasis, and every part of the chest, okay, be it the pleura, the lung fields, the chest wall, none is exempted from metastatic chest disease. So what you get to find most of the times are pulmonary nodules of varying sizes and numbers. You can find areas of consolidation. You can have cavitatory lesions. You can have features of lymphangitic carcinomatosis. You can have cystic metastasis. Okay, you can have pulmonary ossification, hemorrhage. You can even have pneumothorax as a sign of metastatic disease from various parts of the bodies. Okay, so this is a frontal chest radiograph, okay, that demonstrates multiple rounded opacities of soft tissue densities, okay, projected in both lung fields, okay, of varying sizes. Okay, so this was a feature that was seen in a patient that had cervical cancer. Okay, so this is also frontal chest radiographs that demonstrate thickening, prominent pulmonary vessels, background nodular shadows, thickening of the interlobar features. Okay, the CTR and aorta and other structures are essentially within normal limits. These were features that were seen in a male patient that had prostate CA with features of lymphangitic carcinomatosis. Okay, this is also demonstrating multiple pulmonary nodules within the chest, okay, of similar sizes, okay, projected in both lung fields. So the treatment options for these patients are usually, it can be medical, it can be interventional, it can be surgical, depending on the cause, okay. So in conclusion, chest radiographs are very vital in examination of patients that have both respiratory and cardiovascular symptoms, but it is rather very unfortunate that at this point in time, we are talking about chest radiographs only in evaluation of our patients, because I think the world has gone far ahead of that, but we have to just make use of what is available to, lower the rate of morbidity as well as mortality. So thank you very much for your time. I hope I was not too fast. Thank you very much. So please, I will entertain questions if you have any. Thank you. Hello.
Thank you, Dr. Sarah, for this wonderful and very educating presentation. X-rays, I think, one of the most available diagnostic listing that is available even in our primary healthcare centers. And it's good that you've educated us on some basic knowledge on how to interpret our chest radiograph, even in our local settings. And I'm sure many of our people have benefited from this presentation. I think let's see if there are questions on the chat box for you. Okay, we go through the chat box. Okay, this one has already passed. Somebody says, is it possible for a pointer to be used? That one has already been taken by event. The next one is, say, after talking about pleural cavity on slide 21 or 22, before talking about CCF, I think it would have been nice to say a word or two on the chest finding in pulmonary tuberculosis, which is a common everyday finding now. Okay, so maybe you probably, what you say, maybe you need to also educate us more, particularly on pulmonary tuberculosis, since it is very common. Don't know if you can still do that.
Okay.
Then the second, you can note it so that you can take everything at once. The other one, thank you for your ongoing presentation, Mark. Can you please help us the pointer? Okay, still the pointer has gone. Yeah, well done, Mark. Very educative and interesting timely presentation. Questions, what are the contraindications for chest radiograph? Okay, so I think this is what we have on the chat box. We can respond to the two questions.
Okay. 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 So for pulmonary tuberculosis, actually is a wide topic. But for the radiographic features of pulmonary tuberculosis, it depends if it's a primary pulmonary tuberculosis or secondary pulmonary tuberculosis, okay? So the primary one, you get to have pleural collection, lymphadenopathy, and consolidative changes, okay? Especially in children, okay? So, but for the, and it predominantly affects the upper lung fields, like we know, except of course, if the patient has immunosuppression, okay, so it can affect other parts of the lung fields, okay. So for the post-primary pulmonary tuberculosis, it's a range of
Fine.
findings that you get to find on a chest X-ray, depending on the stage that you pick it. You can have reticulonodular opacities of soft tissue densities. You can have features of lung collapse, like we have discussed. You can have destroyed lung syndrome. You can have pleural collections. You can have bone focus. You can even have miliary TB, where you have small 1 to 3 millimeters of widespread
We're almost
innumerable
rounding this one.
opacities of soft tissue density on the lung fields. Okay, so it's actually a wide range of findings that you get to see. Okay, you can even find cavitatory lesions. Okay, thick wall irregular cavitatory lesions, depending on the severity and the degree that you get to find it, the particular patients. I hope I've answered the question. Hello, sir.
Yeah, it's okay. So the one say any contraindication for chest X-ray.
Yes. Well, not really an absolute contraindications per se. If a woman is pregnant, okay, if you have to do a chest X-ray, you have to do it with a lead shield, okay, and then patient refusal to a patient can tell you he's not interested, he has heard about X-rays and all of that. Is also a contraindication, patient refusal. And then if a woman is pregnant, you have to protect the child, so you may have to use a lead shield for the chest X-ray. I think those are the two that is quite handy for me. I've not seen a particular patient that said chest X-ray was difficult to perform or stuff like that. So I think those are the two ones that are quite handy with me now.
Okay, thank you.
Yeah.
Okay, there's some. I don't know. Let me see again if there's still another one. Yeah. So is the deep dual, is it sulcus or dulcus you want to say, now sign an abnormal sign? Difference
Yes, it
between
is an
it.
abnormal sign.
Yeah. So what's the difference between it and the DSS and costophrenic angle?
Okay, the
Then
difference between deep sulcus sign and what?
And costophrenic angle.
Okay, the costophrenic and in deep sulcus sign. Deep sulcus sign is a sign to indicate that there is recollection within the pleural space. So you get to find an abnormal deepening of the sulcus, but it is hypertransradiant, meaning that it's a bit darker than usual. You tend to compare on both sides, okay? You will see that it's darker than usual and then it's deepened than usual. So that's what the deep sulcus sign is. It's a sign of pneumothorax. It's seen mostly in supine radiographs, especially in critically ill patients.
Yeah. Yeah. So
While
the
the
other one,
costophrenic angle is normal.
other question is, Ma, please, what are the modern alternative radiological modalities other than chest X-ray? Thank you for your highly informative.
Okay. Other imaging modalities. Basically, we have CT, we have MRI,
Yes.
okay, in evaluating the chest. Okay, so it's unfortunate that we have found ourselves in the deep side of the topics that we are still talking about chest radiographs, because in all truth and honesty, I think the sensitivity of some of these disease conditions are very, very, very minimal using chest radiographs. In developed world, they hardly even look at it. Okay, so it's just unfortunate that we just have to talk about it. But maybe moving forward, when we have CT scans and other things, even our diagnostic accuracy will be able to increase. Like all these COPD, chronic bronchitis, emphysematous changes, and all of that. The sensitivity of radiograph is so minimal. Okay, what is used to diagnose them is high resolution CT scan, where you can really evaluate the chest and other structures so as to confidently make your own diagnosis.
Okay, thank you. So this is also comment. The importance of clinical history from the clinician cannot be overemphasized in making sense of chest X-ray findings. The image on lymphangitis carcinomatosa, for instance, if you know that the patient has a history of breast cancer, for instance, it makes it easier for you to clinch the diagnosis and not think in the direction of interstitial lung disease. Okay, so this is just an
Yes.
information for clinicians to provide clinical information for, for radiologists when they are requesting for any image. They need to provide the clinical information because it will guide them in helping you make
Yes, sir. Clinical details. The clinical details are very important because a lot of things look alike. A lot of things look alike. I think there was a time that we spent 2 hours with a doctor trying to trash a particular radiograph. Okay, so clinical details is very important. You can just look at an image and say somebody has chest infection. Meanwhile, the person has something severe as lymphangitic carcinomatosis. Okay, so clinical history and then examination is very important. Okay, so as to align and rule out other disease processes that occur in the chest.
Okay, the next one says, thank you for your presentation. How can you differentiate between molarity TB? Is it miliary he wants to say, or molarity? Miliary TB and metastatic feature on radiographic image.
Okay. First of all, the distinguishing factor, okay, has to come from, first of all, you have the clinical detail as to what the patient presented with, okay? Then second is that miliary TB, they are fine, nodules, 1 to 3 millimeters. You see them widespread like a veil, not sparing any part of the lung fields, okay? You see them everywhere. I'm not trying to say that metastatic chest disease does not present like that, but the nodules of metastatic chest disease in most times are usually bigger than that of miliary TB. So, but the clinical history is what just gives it out, because metastasis can take any form. What metastasis cannot do does not exist. So it can take any form. Okay, so they may look similar, but when you have the clinical details and you examine the patient, you should be able to know as to what is particularly causing the disease condition on the particular chest radiograph.
Okay, so still emphasizing on the importance of clinical information if you are requesting for NHS radiograph or any image for that matter. The importance of your clinical information cannot be overemphasized. It is key in arriving at your diagnostic value for the images you are requesting. Yeah, the next one said, thank you. Can I get the slide? Yes, if you are part of the NMA blog, it's actually going to be posted on the NMA blog for everybody to have access to it. But if you are not, then you can reach us privately so that we can send the slide to you. Okay, somebody has also sent his email for the slide to be given to him. It is noted to be shared with you if you are not part of the NMA Taraba platform. Still, this one requesting for the slide too, he has sent his email for it to be sent. Then this one says resources availability and socioeconomic status and universal health insurance coverage and accessibility are some of the factors that make CT and MRI inaccessible to the majority of the populace. Yes, we know that. And it's indeed, even where it is available, it is not easy for people to afford to have it done for them. So I think, let me see if there's any hand up that want to make comments. Okay, I can't see any virtual hand up. Okay, so I think I can't see any virtual hand up, and we've exhausted the chat. Yeah, there are no other questions on this one on the chat. So thank you, Dr. Zara, for this wonderful presentation. Thank you for taking your time, and educating us this morning. We appreciate you, and we thank you once again.
It's always my pleasure. Thank you so much. Thank you so much. I'm also available. This is just a brief presentation. So in case you have any radiograph you'd like to discuss with me or what, I'm also available for that. Even the person that spoke about TB, we can also discuss at our own personal time, discuss other features with some radiographs we share and all of that. So I'm available for any form of other discussion. This is just an overview so that when you look at a radiograph, you just have an idea as to what you are seeing even before your report comes on. So thank you for your time. I really appreciate you all. It's my pleasure. Good morning.
All right. Thank you. Good
Thank
morning. Yeah, so we go to the next presentation, and the next presentation is going to be taken by no other person than our chief, Dr. Sani Wada Philip. He's a consultant obstetrician and gynecologist with Federal Medical Center, Jalingo. He's going to take us through screening and early detection of cervical cancer among women. This is also an interesting, discussion, and I urge us to listen attentively, drop our questions on the chat box, and or raise our hand if you want to make comments or make contribution at the end of his presentation. Dr. Sani, the floor is yours now.
Chairman of NMA, the Chairman of CME Committee, and colleagues. We are going to have a discussion on the prevention and screening for cervical cancer this morning, and I'll be going through with the following outline. I will first introduce and mention the burden of the disease and the risk factors. We talk of the methods of prevention, screening, and then the methods of screening, our problems in the developing countries, and then conclude. By way of introduction, cervical cancer remains an important public health concern worldwide, one of the most important causes of cancer mortality among women in Nigeria. Globally, the fourth most diagnosed cancer, and globally it's also the fourth leading cause of cancer death. Human papilloma virus, HPV, is the most common sexually transmitted infection worldwide, and pre-invasive lesions and cancer are initiated by the persistence of this virus. There are a number of serotypes. You have the low-risk serotypes, you have the high-risk serotypes. For the serotypes of the HPV that are oncogenic are the high-risk serotypes, and they are 16, 18, 31, 33, 35, 39, 45, up to 82, as you can see on my screen. Multiple serotypes can act synergistically to cause cervical carcinogenesis. This has to be emphasized. That means a woman can be infected not just by one serotype, but a number of serotypes that can act synergistically to cause carcinogenesis. Infections with type 16 and 18 are most grave. In Nigeria, about 60.9 million women are at risk. And of course, it's the second most common cancer among women worldwide. Nigeria experiences 13,676 new cases and 7,093 deaths annually, which is a very big burden on our country. What are the risk factors? Human papilloma virus is responsible for 99% of cervical cancer. Type 16 and 18 are responsible for 70% of cancer of the cervix. Well, other risk factors are cigarette smoking, the use of oral contraceptive pills, patients that are immunocompromised, Dietary factors like deficiency of vitamin A and folic acid are contributory factors. There are sexual factors too, multiple sexual partners, early age of first sexual intercourse, male partner, of course. Reproductive factors, multiparity. You know, in Nigeria, many women will want to have so many children. Multiparity is a factor. And low socioeconomic factors are also responsible. Those we discover that those that are of the low socioeconomic factors are those ones are not able to the health-seeking behavior because it's just due to financial constraints. How do we prevent cervical cancer? Well, cervical cancer is a preventable disease. So therefore, death due to cervical cancer is also preventable. The pre-malignant stage is detectable, and effective treatment for pre-malignant stage is also available. So death from cancer of the cervix, of course, when patient presents at a late stage. So those late stages are stages 3 and stages 4. What are the methods of prevention? When we talk of prevention, we classify into primary prevention, secondary prevention, and tertiary prevention. Now, primary prevention, we have to talk of counseling. Do we counsel mothers to talk to their daughters about early sexual debuts? That later in life, as they age further, the chances that the cervical epithelium will be more mature and therefore less prone to infection will be, if they have that knowledge, it will really help them. So it's good to counsel mothers to talk to their children. Then creating cancer awareness through health education and advocacy. General population creates awareness about cervical cancer and then educate them. And the leaders, the gatekeepers, can be informed of the the community to improve on health-seeking behavior. Then the avoidance of precipitating and risk factors, and in fact, vaccination. These ones constitute the primary prevention. When we talk of secondary prevention, we now talk of screening, and the idea is to screen. When you screen, you can detect the problem, and then you can treat, even at the pre-invasive stage. So early detection is important. For tertiary prevention, already the woman has reached, the disease has reached an invasive level. And at this time, all you do is to treat the disease and mitigate further damage. The primary prevention. Well, the first in line now to think about in primary prevention is actually vaccination, and that's the most important. So I will talk briefly on the vaccine development. The human papilloma virus, or viruses, are small non-enveloped viruses, 8 kb circular with 8 kb circular genome, and each one encodes 8 genes with 2 encapsulating structural proteins, which are called L1 and L2. The transmission is mainly by skin-to-skin contact. Vaccine development is based on recombinant virus-like particles. What we mean by virus-like particle is that this particle is not the virus itself. Okay, the L1 protein, another organism is made to produce the L1 protein, okay, which is now incorporated as the vaccine. Okay, so it does not have any DNA, so it cannot replicate, to cause any viral infection. So, and that way it has no oncogenic potential. That means it has no ability to cause cancer. Well, on the slide too, you will see the characteristics of available human papilloma vaccines. The manufacturer, the FDA approval, and then other characteristics that are mentioned there. And of course, as you go down, you see the doses of the vaccine. All of them seem to have the same dose, that's 0.5 mg per dose. Also, you have adjuvants that are added to it and absorb the amino hydroxide in the cervix. Then amino hydroxide sulfate or sulfate in the Gardasil. You have Gardasil 9, amino hydroxide sulfate, as the other one, Seculin, was manufactured in Ghana and it had been licensed in 2020. I mean, not Ghana, I'm very sorry, it's China. All right. Then all the abbreviations are we have given you the meanings there. FDA, Food and Drug Administration, HPV, human papillomavirus, NPL, monopoforeign lipid and the virus-like particles, DLT, and EMA, European Medical Advice Medical Agency. That is where we got this information about these vaccines. Now, the schedules for the vaccines, the idea is to make sure young girls get vaccinated. Young girls between the ages of 9 and 14 years. Okay, and it's a 2-dose schedule for those girls at 0 and then 6 months. That's what is recommended. Those that are greater than or equal to 15 years, they have 3 doses of schedule. That is at 0 and 2 months and then 6 months. That's the recommendation. We have an immunocompromised patient. They also have to have a 3-dose schedule, which is 0 to 6 months, recommended also. There's what we call the catch-up vaccination, and it's recommended for persons through the ages of 26 who are not adequately vaccinated. It's what we call the shared clinical decision-making regarding human papillomavirus vaccination. And that is recommended for some adults aged 27 to 45 years. It is to be noted that human papillomavirus vaccines are not licensed for use in adults greater than 45 years. It is to be noted that any woman that's above 45 years is no longer entitled to the vaccine. Now, let's talk about the secondary prevention. By secondary prevention, we are talking of systematic application of a test in an asymptomatic person to detect preclinical conditions. Your patient is coming with no symptoms. He's not complaining about anything wrong in the area of the cervix. She may come to clinic with another complaint. But the aim of the screening is also to identify precancerous cervical lesions and to prevent development of cervical cancer and early stage invasive cancer. What are the types of screening? Screening can be selective if you are talking of screening high-risk groups. It can be mass screening. You are thinking of the whole population of women in a particular area. And it can be opportunistic. If a woman comes to the clinic with a different ailment or a different complaint, and you say, Madam, have you ever heard of cancer of the cervix? You say, I've not, or I have. Have you ever screened? Have you ever been screened for this cancer of the cervix? He says no or yes. If it's yes, when? And if it's no, you start telling her there will be need. Then that is what we call the opportunistic screening. And then you enroll her for the screening. Well, the criteria for a screening test, as outlined by the World Health Organization, it must be simple, and the screening for cervical cancer actually is simple, must be sensitive, and it must be specific. It must be cheap, that is, it must be affordable, and it mustn't be cumbersome. That is, it has to be acceptable to the population. It has to be accurate. It has to be reproducible. That means whatever results we present in a particular center, when it goes to another center, that result should be acceptable. So it should be reproducible. Or the patient decides to go and do the same test elsewhere, it's expected to have a similar report. By sensitivity, we mean the probability of a test to be positive when the disease is present. And by specificity, we mean the probability of a test to be negative when the disease is absent. So what are the benefits of screening? Early detection improves prognosis and decreases what? Morbidity and mortality. The treatment is less radical and simpler and cheaper, and the patient can be reassured and of increased survival. And that way the patient can be happy with the clinician. What's the plan of World Health Organization? The World Health Organization has designed strategies for eliminating cervical cancer by 2030. That is what is called the 1970-90 Global Strategy for Cervical Cancer Elimination. And that means that 90% of girls should be fully vaccinated by the age 15 years. And 70% of women are screened with high performance tests by the age of 35 and 45 years. And 90% of women identified with the cervical disease should receive treatment and care. Well, fortunately, I would say very fortunate, our country, Nigeria, has developed the strategy to meet the World Health Organization targets. The National Cervical Cancer Elimination Plan for Nigeria represents our nation's bold commitment to meet this target. Do we have challenges? Yes, there are challenges. The stark reality is that only 13.5% of Nigerian women have ever been screened, and about 80% of cases are detected too late for effective treatment. The vaccine uptake by the young girls may not be optimal. There are also myths, false beliefs concerning the human papilloma virus vaccine in developing countries. As we have seen from the table that I gave on the various vaccines, there is no content of the vaccine that has something to do, with prevention of pregnancy. There's nothing that is contraceptive about the vaccine. But you hear some doctors tell people that this vaccine, some people may have incorporated some medications that may cause infertility. So if you are going to, vaccinate these girls, they are likely to end up in their husbands' houses not having children. So these are the myths, these are the false beliefs that are setbacks in the use of this vaccine. What are the strategies? Through the National Cervical Cancer Elimination Plan for Nigeria, which is an evidence-based roadmap to eliminate cervical cancer, to prevent through widespread HPV vaccination. In 1923, this country, we succeeded in getting about 12.3 million girls vaccinated. And by 19, it's expected that by this 1925, um, by this 2025, in 2023, we got about 12.3 million girls vaccinated. And in this year, 2025, it's expected that they should be reaching about 15 to 16 million that must have been vaccinated. So we try to treat women that have the diseases through strengthening health systems and equitable access to care. Well, there's a lot to do. There's a lot to do. Strengthening health systems and equitable access to care. I know we have a lot, but our hands will be on deck. So what are the modalities? The nomenclature for the screening. We talk of cervical intraepithelial neoplasia, CIN. When we say CIN1, detecting at the pre-invasive level, we say it's mild. When we talk of CIN2, we say that is moderate. We say it is severe. Now, squamous intraepithelial lesions include low-grade SIL, which is equivalent to squamous intraepithelial lesion, which is equivalent to CIN or a positive human papilloma test. Then you have the high-grade squamous intraepithelial lesion, equivalent to CIN2 or CIN3. So based on this grading, the treatment is worked out for such a patient. There's a pictorial representation of what the cells will look like if it's CIN1, what the cells will look like if it's CIN2, and what the cells will look like if it's CIN3. This is actually basically what the pathologists will normally. So as you can see, cervical intraepithelial neoplasia, 1, 2, 3, pictorially presented. Now, requirements for prospective screening program as outlined by the World Health Organization. The conditions to pose an important health problem. Yes, cervical cancer poses an important health problem in the community. In our communities, even worldwide. Disease natural history should be well known. We now know that 99% of cervical cancer is associated with human papilloma virus. There are adequate facilities for the diagnosis and treatment of the abnormalities detected. Yes, we have tertiary health centers where we have pathologists that can carry out, so that they can make accurate diagnosis and when abnormalities and detect abnormalities which can be treated. The cost of the screening program should be balanced against the benefits it provides, and then should be suitable and acceptable test. Those are the methods of screening. We have cytology, human papilloma, virus testing, we have some visual testing. Cytology, we talk of conventional perpendicular smear or liquid-based perpendicular smear, or we call it monolayer because of the way the cells are arranged. Then you have automated cytology screening. Well, the unaided, we have visual inspection with acetic acid or visual inspection with Lugol iodine. We do colposcopy when it becomes necessary, can do cervicography, can do what we call gynoscopy. The conventional pap smear test. This test became popular in 1941 following the report of and is widely used globally. It meets the requirement and is fairly tolerated by patients, is easy to administer, reasonable sensitivity and specificity. Detection of endocervical lesions are very easy. The cytology precautions. When the patient is supposed to come for the pap smear, you have to advise the patient has to be counseled that please, when you are coming, it's not a time that you and your husband must have played a little bit, or you use vaginal gauze or medication. Don't use any lubricants on the private part. No use of powder, or it's not a time that another doctor somewhere will do a pelvic exam on you because of the powder that may appear on the gloves and then other requirements. Now, what are the instruments and the materials that you're going to use? We use speculum. We use speculum. We use in fact the Costco speculum to be specific, and we use the spatula or cyclable brush or cotton teeth swab for endocervical canal. If I Aries spatula is for the endocervix, you have the fixative, usually it's alcohol, in a jar, and then you have the slide. These are the requirements. Very easy, isn't it? Then taking the sample from the ectocervix and endocervix, either with the spatula or brush. Actually, if one is to do the conventional pap smear, you use the spatula for the collection of specimen. But if you are going to do liquid-based pap smear or monolayer, you can use the cytobrush. Then the staining will be in a circular, after taking the specimen, staining the slide in a circular motion. Use alcohol, ethyl alcohol to fix. The fixation is by ethyl alcohol. After the fixation, it's examined under the microscope by specially trained technologists or a doctor. So there are people that can be specially trained for this pap smear. They're not necessarily, it's not necessary that all of them must be doctors or pathologists. So, well, this is the normal cell appearance, and then you have the atypical squamous cells of undetermined significance. So when you see cells like this under the microscope, it's described as ascuous, atypical squamous cells of undetermined significance. Then the other one, the next one is the LSIL, that is low-grade squamous intraepithelial lesion, and then the high-grade squamous intraepithelial lesion. And as I said earlier, CIN2 and 3 equivalent to high-grade squamous intraepithelial lesion, while CIN1 is equivalent to low-grade squamous intraepithelial lesion. So depending on what is reported, the doctor can classify and treat the patient accordingly. Well, liquid is very important that I should dwell a little bit on liquid-based cytology because we are supposed to be moving forward, not backward. For forward movement, I'll talk about liquid-based cytology. Cytobrush is used for the collection of cells instead of the spatula, and the brush head is shaken vigorously so that the cells can actually get detached, or they may be broken up into a small pot of liquid containing preservative solution. Then the filtration of the sample or centrifuging is done to remove debris and blood. The cells are then transferred to the slide in a monolayer. Staining is carried out, and the slide is examined. Yes, what are the advantages of liquid-based cytology? It removes most mucus, the proteins and fresh blood cells. The cells are uniformly distributed, and it improves vision and maintains diagnostic clusters. Yes, let's do a little bit of comparison between the liquid-based cytology and the conventional pathway. The liquid-based cytology has less false negative rates and less repeat smell rates, because sometimes the specimens will be taken to the lab and they say inadequate. The pathologist will report inadequate specimen. But with liquid-based cytology, actually, that repeat smell rate is about 1 to 2%. But with the conventional pass smell, it's up to 9%. So it is better in predicting the cervical intraepithelial neoplasia, or no difference in the relative specificity when high or low grade squamous intraepithelial lesion were considered as cutoff. It is the preferred tool. It is the preferred tool for cervical cytology screening as of the moment, where the facilities and the manpower and all that it takes are available, but it's more expensive. It's more expensive. Well, that's a pictorial representation of the liquid-based cytology. Cytobrush used, then the attachments of the cells into a pot, and preparing of the slides. You can see a woman holding that pot there. It's a process. And eventually, the result of the process is also seen on the pictorial. Now, automated pass smell is actually for mass, mass screening. But in all fairness, I'm not sure of any of our hospitals that uses automated pass smell as of the moment. But we are sure of the use of this method in the developed world. They refer to us as low and middle income countries. They are the developed world. So things are better with them. Whatever is costly and whatever is very effective, also most of the time they are able to afford them. We pray we'll get there. Well, we'll talk about human papillomavirus DNA testing. Several approaches are available. Hybrid capture, and the sensitivity is very high for oncogenic human papillomavirus. We use polymerase chain reaction. I know that polymerase chain reaction is used in several centers in Nigeria as of now. I think that is kudos to all of us, whether government or as civil servants, as marketers. I think with PCR available in most of our hospitals, we should be grateful to God. Justification for HPV testing in cervical cancer screening. Well, we have mentioned that human papilloma virus infections are very common, quite common. And most infections with human papilloma virus types are benign because most women, let's be very realistic, although the infection is very, very common, but most women with their immune system, they are able to eliminate, about 90% of them will eliminate the virus via their own immune system before the age of 30 years. So those that will come down with the cancer will be fewer. So a persistent high risk human papilloma virus and this progression to invasive cancer takes 10 to 20 years. So it takes more. I want us to take note of that because you will now ask, why is it that the time of fascination is like this, is or that, you know, because of what? That the progression to invasive cancer takes about 10 to 20 years. Okay. Benign screening, you can begin screening with HPV at 30 years. A woman can begin screening with HPV screening at 30 years. But for using the pap smear, they can start at 21 generally. According to ACOP, it has to start from 21 every 3 years until 30 years. You know, and after 30 years, it can be 5 years up to 65. You know, and then, but when HPV testing is done along with it, you know, the interval for the next screening, I mean, for the screening can actually be increased. You know. Cytology suffers from inherent subjectivity. So, when human papilloma virus testing is carried along with the cytology, you know, there is some increased confidence we have in that result. The sensitivity tends to now be high. Human papilloma virus testing is objective and is highly reproducible. So high-risk human papilloma virus is detected in almost all, like I mentioned before, 99.8% cases of cervical cancers. Hence, the rationale for using it in cervical cancer screening programs. That is the justification. Well, can we visualize the cervix with unaided eye or with aided? Yes, can we visualize? All you do, put a patient in a little position, use your speculum, lipospeculum, then apply the acetic acid. Then acetic acid treated cervix now, you look at the cervix that is treated with 3.5% acetic acid. And the aim is to detect CIN. But good lighting is important. Visual inspection with acetic acid may particularly be useful in the developing world. Consider our women in the rural areas, you know. Some of them cannot easily travel to bigger centers for their tests. So, the hospital that is close to them, you know, with the availability of acetic acid, you know, it's even called vinegar. You can easily be tested. You know, so there may be an attractive progress, even in a well-to-do setting. It may be an attractive progress in a well-to-do setting because of the sensitivity as well. So, the visual inspection is acetic acid continuous. We can also magnify visual inspection with Lugos iodine. It's the same principle. Just apply the Lugos iodine. The normal cells contain glycogen. The dysplastic cells fall in the glycogen content. So when you have brown or yellow appearance, you know that you know those are the normal cells. And those that cannot take up the Lugos iodine, you now know that those are the dysplastic cells. Well, colposcopy, yes, because most of the patients that have CIN2, CIN3, may be referred now for colposcopy, you know, for more examination, detailed examination, and sometimes one might have to take a biopsy. You call it colposcopy directed biopsy. So indications, multicentric disease, because while you are doing colposcopy, you are as well looking at the vagina. Okay, you look at the vagina, you know, you look at the cervix, you look at the other parts of the genital tract, you know, those parts. So if there may be a clinically suspicious cervix on speculum examination, you can send such a patient for colposcopy. The woman may have postcoital bleeding, which may be an early symptom of the CA cervix. And then there may be intermenstrual bleeding as well. Early symptoms. You know, basic requirement for colposcopy: good apparatus and instrumentation. Important, very important, good communication between the cytologist and the colposcopist. That means that when the colposcopist is sending, the colposcopy directed the biopsy specimen to the cytologist or the pathologist, there must be good communication. This is what this area of the cervix, this is what I found, this area of the cervix, this is it, this is it, this cremocolumnar junction is like this, the position and everything. A good description will now guide the cytologist to examine this specimen very well. And that is what we mean by good communication here. It's not just sending without writing some brief findings on the cervix. Training of the colposcopist must be of the highest standard. And patient referred for colposcopy must be properly counseled. She must be informed why you are sending, why the patient is being sent for colposcopy, what you want to find, what you are likely to find. And when there's a leaflet, you can educate this patient with a leaflet on colposcopy. That will now provide essential information to the patient. Quality standard in colposcopy and cervical pathology is very important. For instance, in the United Kingdom, there's a national colposcopy and quality assurance group that oversees quality standards. The pathologists may know if they have a group now in our midst, but I don't know. That would be a discussion among the pathologists. Unfortunately, I tried to call the pathologist this morning, and his phone rang. Probably he was busy. He didn't pick. Clinical data slides and digital photography must be computerized. Okay, so good record keeping. Digital photography. What somebody sees on the cervix, keep a digital photography, so that when the cytologist wants to see the picture of what has been sent, it should be reproducible. The cytologist should be able to come and see, or it can be sent to the cytologist. That will guide the cytologist. So this is just a picture to show the colposcopy apparatus in use. You can see the woman there using the machine, the colposcope, to look at the woman's cervix to see what kind of lesions can be found. So that is just for illustration. Well, there's what we call photography. It involves examination of magnified photographic documentation of the acetic acid impregnated cervix, and its sensitivity to detect high-grade lesions is lower compared with cytology in VIA. Okay, the specificity is, however, comparable to that of cytology. Okay. Its use as a primary screening test in developing countries is unlikely due to the equipment involved. So cervicography is not commonly handled in our used in our environment as of the moment. We are making do with our pap smear, with liquid-based cytology, and of course the colposcopy and other ancillary investigations that will help us make our diagnosis and move ahead. We'll get there. We'll get there. I believe we'll get there. This is just to show what cervicography looks like. You know, the pictures, the photographs, and then when you look at the photographs, look suspicious, you go further and do whatever is necessary to ensure that the woman gets well. Cervicography pictures, very attractive pictures. We'll get there. There's polar probe. Polar probe is an electronic device, for detection of cervical neoplasia. Normal and abnormal tissues are easily recognized when it is applied to the cervix, and it may be used as an adjunct to cytology or as a primary screening test. There is similarity in sensitivity with cytology. So we are still doing well. Whether we use polar probe or not, we are doing well. Specificity is better than cytology in some settings anyway. And we are moving for further trials. Most of other trials in the polar probe is also in progress. I also have a picture, of the polar probe, although it's not commonly used in our environment as of now. Not many hospitals have it. Maybe some private settings. I don't know. Yeah, this is what it looks like. Just have a look. Then there's a heating tip. It's like a thermocoagulator. There's a heating tip. It has a chamber for the bathroom, and it's economically designed handle. Very, 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 very nice instrument. One can lay hands on it anyway. We'll get there. We'll get there. So, visual inspection with acetic acid and Bile. I'm just trying to take these ones together. Visual inspection with glucose iodine based on the concept that either pre-invasive or invasive lesion can even be seen with the naked eye, And the advantages, please let me be very clear about the advantages of this Bile and visual inspection with acetic acid. Apart from the fact that the rural women can really benefit from this, it can easily be taught to other health workers. Midwives can be taught. Nurses can be taught. The paramedics, the community health extension workers, and so on. It just needs like 4 to 10 days to teach them. They go and apply it because they are the people that are in the rural areas mainly. So they can take care of the rural women with this. And when they notice that there is need for further referral, they will refer to us. And we'll be able to help such women. It's not everywhere we can do it. We just need people of assistance, We need people. So we need to teach some health workers. And this method has that advantage, because the health workers can easily be taught. Acetic acid and glucose iodine are widely available and inexpensive. I have mentioned that earlier. So the visual inspection technique has been evaluated for low and middle income countries. We are getting out of that level. We'll get there. Low and middle income countries. We'll get to developed level very soon. Let me continue with that. For BIA, well-defined asserting white areas in the transformation zone following impregnating the cervix with 3 to 5% acetic acid. And a positive result is based on that appearance. For the glucose iodine, is the positive results based on appearance of definite yellow area in the transformation zone. Okay, there is what they call self-sampling testing, which we are yet to teach our women. Well, the visual inspection also can be aided, what we call gynoscopy. You can use a low-powered monocular telescope, very light, and it has light weight. But how much better than unaided eye has not been studied and well elucidated. Um, well, may I say, I should conclude, the burden of cervical cancer is enormous, being the third most common cancer found in women after lung and breast cancers. The World Health Organization targets of 90-70-90 global strategy for the elimination of cervical cancer is timely. It's quite timely. On our own part in Nigeria, our National Cervical Elimination Plan for Nigeria, okay, provides a clear, evidence-based roadmap to eliminate cervical cancer as a public health threat by 2020. All we need to do is to be committed, put our hands on deck. And in fact, the time to act is now. The time to act is now. I thank you for listening. Thank you, and thank you very much.
Okay, thank you, Dr. Fani, for this elaborate and wonderful presentation. Cervical cancer is one of the commonest cancer we have that is ravaging our communities. Either it's affecting a neighbor, a sister, a wife, and a lot of women probably are suffering from this easily screened, easily identified early cause. Yeah, but because this prevention and screening facilities and knowledge is very limited in our rural areas, that's why we still see many of our women coming with advanced disease. And it's good that this lecture is coming. I hope many of our doctors, particularly in the rural areas, are part of this presentation so that they will benefit maximally, from this presentation. So thank you very much, Dr. Sani, for the extensive presentation. It's really enlightening and it's educating to all of us. I don't know, we'll go to the chat box to see if there are questions or comments there. Let me see if there's any hand up before we go for the question. Yes. Dr. Lawi Rimansukwe. You can unmute yourself, yes, and then go ahead.
Yes, good afternoon.
Good afternoon. You are clear, yes, you can go ahead.
Yes, for some of us in the rural area, there's a small good news and there's a small bad news in the aspect of the screening. Some NGOs, particularly the ones that work with HIV programs like RISE that recently handed over to Annie, they are actually supporting the screening using the VIA, but they only restricted it to their HIV clients. It does not cover other clients that are not HIV. So when we get them and want to refer them for screening in the tertiary institution, especially at Jalingo, most of them used to find it difficult traveling to Jalingo. So that's the only basic challenge we have for now. Thank you.
Thank you. I think Dr. Sani will respond to, maybe he will respond to that. Okay. Let me see again if there's another hand up. Okay, I think it's the only person that's raised his hand to talk. The chat box, you can maybe write the question so that you can answer it as you go. Or maybe I should be reading it one after the other. Okay, so maybe if you want to respond to this one, go ahead and respond. Then I'll read the question subsequently.
Let me quickly talk to this person. Where is he speaking from? Where are you speaking from?
I'm speaking from General Hospital, Bambur.
Oh, Bambur!
Yes.
Oh, Bambur? Yeah, I can understand. Yes. When I came, wow. When I came to Bangladesh, about Bangladesh, it's a very difficult. So I'm not surprised that these women will find it difficult coming to Jalingo. But there has to be a way out. Usually during the dry season, I think the roads are very long for somebody to come to Jalingo, isn't it? I guess. Are we talking? Are we together?
Yes, sir.
Please. Sorry. Now you can help this woman while you are there. God wants you to be there at this time to be helpful to this woman. Okay? You can go extra mile now. Can't you? Huh?
Yes, sir.
You can go extra mile now, Dr. Lawi. You know, in those days, I don't know now, PMOs, they used to have extra, they used to take care of them and they can have some heavy pockets too. Can't you transport a patient from that place? Is it too much?
No, that's not the same thing these days.
It's not the same thing now.
Yes.
Okay. You see, the important thing is counseling. Do you understand? The important
Our
thing,
challenge has been we are pleading with these NGOs. They actually pull out some of our staff to even train them on the basics, the basic screening. They supply the screening materials. So we are pleading with them if they can extend it to these patients that are not HIV clients. If you can at least screen and then refer.
yeah. But the particular group of people that were assisting you before, are you still in touch with them or you have lost touch with them?
They're still supporting us up till now.
They are supporting. So it's a matter of discussion, isn't it? First is to cancel the patient on the need for care in a bigger center. Do you understand?
Yes, sir.
Yes, and especially sometimes you will have to cancel the patient along with the husband. You see, that is the problem we have with this women empowerment. We keep emphasizing women empowerment, women empowerment. You understand? Some of them will have some ailments. They will have to wait for the husband until the husband has money to send them out and all this. So please, just try and talk to such people, the women, and talk to the husbands at the same time so that they will cooperate with their women so that they can move out to bigger centers for attention, for care. Do you understand?
Yes,
Yes.
sir.
Yeah, you know, the one that I said your pockets can be heavy, it was just a joke because even myself now, I know that things have changed. Okay, that's the truth. Eh?
Yeah,
So,
I'm bringing it up because we've tried our best. Despite the counseling, some of them, when we refer them, they ended up not going.
oh my God. You see, that's the real bad situation. Because when you get to a certain level, you know, that by the time you get to 8 years, 7 years, hmm, it's like death is coming. You understand? So please do your best in the counseling. Do your best to talk to some friends. Discuss with NMA chairman. Discuss with NMA chairman. You know how to bring healthcare to Bamboo. You know, maybe as a group. You know, do you understand? Are we
Yes,
together?
sir.
So, well, I like your courage being in that particular place. I know you are doing your best to help the rural population. We are happy with that. As you are helping people through, God will help you.
Thank you, sir.
Thank you very much. I'll try and
Okay.
so that we'll be talking, okay? On the way forward.
Okay, thank you, Dr. Lawi, for your concern. I think it's a bigger social issue, actually. And NGOs actually operate within a limit. They have programs, and they usually don't go outside the program that they've been mandated to carry out. And so it's very difficult if their program is strictly for HIV patients for them to begin to incorporate non-HIV patients into their program. You know, they have this very high accountability for whatever they are using. And so it is actually very difficult for them to go out of the way. I think maybe what can be done, like Dr. Sani said, maybe is still advocacy, you know, to those NGO or for the state government actually to see if what the NGO is providing can be extended. You can leverage on that and extend it to other women who are vulnerable in the community to benefit from such, especially that, you know, the previous NGO has been able to train other people. So it's just to actually get these people and co-opt them into a certain program by the state government, and they will be able to carry out such thing and do it much more appropriately. So I think when you complain from Bamboo, I believe similar thing is happening across the general hospital and the cottage hospitals across the state. And it is also a good forum because at the helm of affairs of the health services in the state are our colleagues. Perhaps they are part of this forum, they are listening, and they can probably see any way that they can actually on it to see how this thing can be extended. The fact that cervical cancer is silent from the beginning is actually what makes many of them, by the time you raise their distance, they are not feeling anything, so they just go home until the thing has gone advanced. At that point, if you say they should come to Jalingo or go to Lagos, they'll go to Lagos because they are feeling problem at that particular point. But during the early stage, many people are unwilling, you know, to make that sacrifice and actually go far. And somebody actually posted, you know, a suggestion on the platform here, and he said any federal legislature in that area can actually be approached, you understand, to actually step into those kind of programs to assist if that case can actually be taken, you know, to them. You know, our politicians too, they have their priorities. It may not be the priorities of the community, but if we can actually do that advocacy for them, You know, for instance, if you notice that you have this large number of such patients who are not able to come in Karim, I think maybe having time with those representative House of Assembly member, House of Representative, if it's from Karim, as this one suggested, or well-meaning individuals can actually be approached, and maybe they can actually go into those kind of assistance. But this is a challenge too for NMA. If there's something they can do, I don't know. There's still the advocacy to our colleagues who are at the helm of affairs in the state to see if this thing can be incorporated. We appreciate your effort in Bamboo, and we are sorry for the challenge and the difficulties you are passing through, which is somehow beyond us. But these are the options. Maybe more options people will also suggest to help you out. Yes, I can see one hand up too. So we give Dr. Nkanta the opportunity to also make contribution, possibly in relation to this challenge we are having. Dr. Nkanta.
Okay, thank you so much, CME Committee Chairman. I have to thank my chief, Dr. Sani has said, spoken very well. In reference to what the PMO of Bamboo is saying, remember when Dr. Sani was discussing this issue, primary prevention, vaccination, and I'm aware government brought this vaccine and people refuse to take them. Vaccine hesitancy is a big problem. So if you can counsel them at that level, it will prevent some of these problems. And then just like both speakers have said, we need to prioritize our health program. Instead of buying MRI machines and keeping them in the village, call postcode. If you can have this call postcode, it can help because it can also be targeted by your collect specimens and send them to higher centers. And then I know that there is no, we don't practice gynae there. And there are some practices that we do there that wasn't their problem. If you see somebody with abnormal vaginal bleeding, just simply inspecting, doing vaginal examination, give her some of these things, and then avoid surgery without doing a pap smear. Sometimes we do myomectomy without doing a pap smear, and it wasn't their problem. Because what we simply do, we end up spreading these diseases. You understand? So the main thing is that cervical cancer is the problem, is killing our people. And the truth is it's preventable. But why we're having problems in our country is because of poverty. That's just the simple truth. So if we are really saying government is eradicating poverty, improving healthcare service, then we should be able to key into this WHO strategy, 70-90. And there is no way you say you are screening for cervical because they say high performance test, and then you cannot do pap smear. That is, we do in FMC, we do in THs. It's better for them to save money once in a while because you do it maybe 3 years, and just like Dr. Sanis, it takes almost 20 years before they develop cervical cancer. So issue of the lack of money, to me, is not an excuse. If it is prioritized, it's something they can do. Thank you very much.
Okay, thank you, Dr. Kanta. So let's go to the chat box and look at the questions available. This one said, very interesting, educative, and concise presentation. Well done, sir. The other one says, pap smear is one of the screening for early detection. Can it be included into health hospital services during antenatal and gynae clinics? And do you think it will achieve any good result? Then I go to the next one. Maybe you can write them. Or try to take them one after the other.
This question now is on. So about pap smear incorporation.
No, it's a pap smear since pap smear is one of the screening tools. Do you think including it into antenatal care services and gynae clinic will make any difference. And then the other one is HPV testing. Is it available in our laboratories? Screening for human papilloma virus, is it available? And if it's available, if the result is negative, can the women then be vaccinated with HPV vaccine? Then we have one single. Oh, okay.
The first question is the first question asked me want to answer. Yes. What we do in our country at the moment is opportunistic screening. All right. So if patients come to gynec with a different complaint element or whatever, we can decide to we must actually request for pap smear. Okay, that is the opportunistic screening we are talking. The only thing that the question one will ask is, must pap smear be restricted to gynec? What if a patient gets to a female patient's reproductive age, gets to the general outpatient clinic? Can they order pap smear with a different complaint? Yes. The answer is yes. The answer is yes. So all hands must be on deck. Whenever you see a patient that comes in, do the opportunistic screening. Okay? The antenatal women, we tend to be more careful. Sometimes, in many cases, we have to think of postponing, except when, there are symptoms that will suggest that we should do something. We prepare, 9 months, before the woman should have delivered, and then we can do what we want, concerning the cervix at that time. But in cases where it becomes necessary, we don't really fail to, intervene. Okay, so that is it. A pap smear anywhere. It doesn't have to be gynae clinic. It can be a surgery clinic. It can be just to complete the form and send to the place where to the area that the specimen can be taken. If the form is completed, that is all. Then it will be sent to the pathologist. You get it? That's opportunistic screening that we are talking about. You understand? So that is about the pap smear. Now, HPV screening. HPV screening, is it available? Where did it go? Huh? In our hospital. Which hospital? Yes. Yes. Yes, the HPV test is expected to be done in tertiary centers using the PCR. It's very common. It's very common. It's very common. The only thing is, I've not particularly sent a patient to do a PCR here, in Jalingo, because I haven't been long here. I'm still trying to study our lab. But I do, since I came, I've been sending patients for Papa Nicholas smear, and I've been getting results. Yes. So I've been told that we do PCR here. So it's not, I've not been through it. We do PCR here, we do some test for HPV here. You get it? Yeah.
Okay, thank you. So,
That also goes to the management of the hospital. Yeah.
uh, okay, thank you. So the next question says, can boys benefit from HPV vaccine? Can boys benefit from human papilloma vaccine?
Yes, this is.
Then number two is, what's the scientific basis for visual inspection with acetic acid and with lugos iodine? What's the scientific basis for it?
No,
And
wait.
then number three, okay. Number one is, can boy benefit from HPV vaccine? Number two, what is the scientific basis for VIA and VILA? VILI. And then the last question is, how often can a woman do a pap smear? How often? Thank you.
Yes, I like this question particularly. Can boys take HPV vaccine? Yes. The answer is yes. The answer is yes. They can. They can. They can because boys can take the vaccine because they too can be carry the, like we said, mucosal viruses, get transmitted from skin to skin contact. Boys can take HPV vaccines, yes. Then the other one is scientific basis for. Okay, okay, okay. Scientific basis for. Okay, Bile, okay. Yes, scientific basis for VIA. When the cervix is treated with the 3 to 5% acetic acid, there's a color change that will be noticed on the cervix. Okay, these plastic cells will produce what we call acetal white appearance. Okay, so the cells that are not actually dysplastic will not change. Okay, for Bile, that is visual inspection with lugos iodine. Okay, the dysplastic, the normal cells contain glycogen. Okay, the abnormal or dysplastic cells have long or little glycogen content. So when the iodine, the lugos iodine, is applied to the cells, the normal cells will now change color, either brown or yellow. We call it filler positive. Okay. So those you will now know that the cells that don't change color now are the ones that are abnormal. You get it? So that is the scientific basis. Abnormal cells, what happens to them? The normal cells, what happens to them? That's the scientific basis. So, and it's something we can easily teach the other health workers. That is a great advantage this method has, and for low or middle income countries. You get it? The other one is how often, huh? How often do we do pap smear? It all depends. But ACOG guideline, okay, that is by ACOG. We are talking of the American Association of Gynecologists and Obstetricians, their guideline says that from the age of 21 years, okay, every 3 years, the woman should, up to 30 years or 29 years now, okay, the woman should have the pap smear done every 3 years, okay, up to 29. As from 30, it can become 5 years. All right. So that's how pap smear is carried out. But if we are combining the pap smear with a human papilloma virus DNA test, then you could decide to increase the interval of the test. But that is if the two can be combined and all that you need are always available. You get the idea. So that is about how often. As for 65 years, except if a woman is HIV positive, she may not need to continue. But if it's HIV positive, such a woman can still, because of the immunosuppression in such a person, the person can still come down with the cancer of the cervix. And that is why such a woman should also continue beyond 65 years.
Okay, thank you so much for the answers. I think maybe I'll just make contribution about the boys for vaccine. Yes, boys are also part of it, just that in Nigeria, for whatever reason, I think for scarcity and the cost of the vaccine, it has been made strictly for girls from 9 to 14 years. It is already in our national schedule as it is now. And but in developed countries where it is not an issue, the cost and this one is not an issue. It is also given for boys. After all, who transmit it to the women? Is it not the boys? So they actually benefit from the vaccine and they actually supposed to be given. You know. Then I think the last question here, sir, before we round up. This one is like a contribution. He said, thank you for your presentation, sir. Given the prevalent rate of this condition and the associated morbidity and mortality rate from the disease, how can these screening materials and vaccines for the identification and prevention of the disease, the current direction in practice, be made readily available, especially to rural communities where most of our people live? How can we make it available for them? And then I think the same person again says, is there any advocacy to ensure the vaccine for HPV is included on the national? I think I've answered the last one. It's already part of the national schedule. It's already part of the national schedule. So advocacy is on.
Should I make a comment? Advocacy is for all of us. Okay, all of us involved, all of deck. Wherever you find the opportunity, you just have to inform this women about cancer of the skin. Anyone that has never screening done, tell them, please, why don't you do that? By the time the person is one, it will be necessary and all this. They don't tell that. The person will understand. So, and good community leaders. And we have to talking to men. Many of them, many of us. We are holding the women down. Bring them to exercise right, their health, posing unnecessary, because it will not help us. So what we need to do is to talk to men as well as the women. The cancer to go, the men to also look at the women to go for such tests. You see, look, as I am talking to you right now, there is one that's really stage 4, okay? And because, there's not much we can do. A woman has stayed somewhere almost 2 months in another bigger hospital. But when they saw that it was to come near home, they are already in the hospital. It's pathetic, isn't it? So, we have to talk to the men, also talk to the women. We have to talk to each other and make sure we eliminate this scourge from our midst. Thank you.
Okay, thank you so much. I think the last one has generated much discussion compared to the others. That's to tell you how people are taking the issue of cervical cancer, serious in our community. The vaccine used to be very expensive then, and then it's only few people who are rich that are able to get the vaccine and then give their children. But now the federal government has made it available. They did a kind of roll up of the vaccine between last year and this year across the state. I think the one in Taraba was done last year here. The advocacy was huge. We went to media station, went to schools, went to markets and so many other places. But despite that, just like the presenter actually said, there are some skepticism and some misinformation still going on about the vaccine. Some will tell you never to take the vaccine. And I think I must share my experience in one church I went, and the man of God was warning the congregation. He has warned them that they are bringing one vaccine, say they are preventing cervical cancer. And he actually told his congregation that if anybody dare to take that vaccine, he's on his own. He has already issued his warning as man of God. And I was just looking in very big surprise that what's the meaning of this? Okay, so those conspiracy theory that the vaccine will cause early ovarian failure, it will cause infertility, it will cause this, it was the same thing. So I could just imagine the member of that church now, how they've taken the message across. And it's really one of the things that is affecting acceptance of the vaccine. But for information, if you're not aware, it's already in our national immunization schedule now. It's for girls between 9 years and 14 years. The vaccines are actually available and they are free. So your daughters, your sisters' daughters, your nieces, anybody that you know around, please spread the message for them. It is available in our vaccination clinic now for people to access it. Thank you everybody for being part of this session. And the last topic that we are supposed to take today, unfortunately for unforeseen circumstances, the presenter sent message late that he will not be able to take the presentation. And so this is the end of our CME for this time. Yeah, so we may have to take his presentation during our next CME, which is also a very good topic for us because it's talking about management of stress and burnout among doctors in the midst of thinning manpower and Japa syndrome. So it will have been a wonderful presentation for us. We know what all of us are passing through. Yeah, but because of some unforeseen circumstances, he's not able to take the presentation this time around. We scheduled him during the next CME presentation, and I know it's going to be great for all of us to to listen to the presentation. Thank you everyone once again for being part of this presentation since 10 o'clock. If listening, we had a good number. At a point, we had almost 36 people. And I think it's a very wonderful outing for us. Thank you, Mr. Chairman. The NMA Chairman is also has joined us, is on the Zoom, and other members of the SOC. Thank you all for your support to ensure that this thing is successful. I won't forget our powerful ICT once again. He has always been a pillar of success for us, both at the NMA and the CME committee. Dr. Bright, I don't know how to call the second name. Dr. Bright has been so wonderful. He has always been available. That even this morning I was teasing him. He has a very understanding wife that is not protesting. Supposed to be at home with her this weekend. We dragged him out since morning. He's here before us to save the team and ensure that our presentation is going on smoothly. Dr. Bright, we can't thank you much. Thank you so much. May God continue to bless you and enrich you with knowledge so that you can serve humanity very well. To our presenters, thank you for taking our time. It's not easy. We've tried to reach so many people who could not agree because they have so much schedule. So, but you've agreed to squeeze time, research, do slides, and then even taking your time out of very busy weekend that many people use the weekend to go for some things for you to do the presentation for us. Thank you so much. Thank you so much. For all our participants, please, we thank you once again for being here. And please, let's have another good time next time so that all of us can enjoy the presentation. This is the end of the second session of our CME presentation. We'll be announcing when we are going to have another session. Our target is to ensure that we have at least 20 CME topics presented within the year so that people can have adequate CME units. So we've so far done 10. We hope that in the next few months we should be able to take another 5 and another 5 or more before the end of the year. Thank you for being with us, and I think I'll close the meeting for now. I don't know.